Thank you, Mariani. The commission will now move to agenda item number 4, consider approval for the meeting minutes from March 23rd. At this time, I would like to invite commissioners to offer comments or ask questions. Seeing no comments or questions being raised, now is the time for members of the public to request making public comment on agenda item number 4 by clicking the raise hand button on your computer or the app, or if by calling in by phone, pressing *9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment now. Also, we would ask that you please limit your comments to 3 minutes or less. Mariani, are there any public comments? Please raise your hand now as the queue will be closing.
I see no comments online, and we have no in-room comments either.
And at this point, I would ask for a motion to approve the March 23rd meeting minutes.
So moved.
Thank you, Commissioner Carnevale. Do I have a second?
Second.
Thank you, Commissioner Rolette, for the second. We have a motion and a second to approve. There's no questions or comments regarding these. All right, then I would ask that we take roll, Jeff, please.
Commissioner Bontrager.
Aye.
Commissioner Boyd. Commissioner Brown.
Aye.
Commissioner Bunch. Commissioner Carnevale.
Aye.
Commissioner Carrillo. Commissioner Chambers.
Aye.
Commissioner Chen. Commissioner Cortese. Commissioner Danovich.
Aye.
Commissioner Gordon.
Aye.
Commissioner Mitchell. Commissioner Rolette.
Aye.
Commissioner Tamplin. Vice Chair Alvarez. Chair Madrigal Weiss.
Approve.
Commissioner Bunch.
Approve. I'm not sure if you guys can hear me.
We heard you now. Approve.
Okay, thank you.
Commissioner Chen. Madam Chair, the motion passes.
Thank you, Jeff. We will now move on to agenda item 5, the items calendared for consent. This includes the approval of innovation projects from Fresno and Stanislaus counties. Commission staff has sent the documents related to these projects to all commissioners at the time of the April agenda, at the time that the April agenda was posted, and a copy of the staff analysis and a letter of support for Stanislaus County have been provided in your packets. These projects had a significant amount of community engagement, not only at the local level, but also through the commission's process, which is outlined in the document in your packets. As a reminder, any commissioner can remove an item on the consent calendar. That item would then be considered as a regularly scheduled agenda item. At this time, I would like to invite commissioners to offer comments or ask any questions. Seeing none, I don't see any. I would like to make a comment regarding Fresno County and their, I want to get the name right. It's a long name. It's the it's Participatory Action Research with Justice Involved Youth Using an Adverse Childhood Experience Framework. I read through this and I want to thank Fresno County for engaging youth that have been in the system and are in the system, and not only engaging them, as in the work, but in the development of this plan. So I appreciate it. I hope to learn from it, and having you serve as peer mentors along the way, and really being thoughtful about asking, what happened? How can we address it? How can the community really rally around you to do better? And having them part of that conversation, I just, it's extremely valuable. And I think our systems, our schools, we do so much to our youth and at our youth, but really having them be part of it from the inception, I just really respect the work. So I just wanted to make that comment. Thank you, Fresno County, for that, and leadership. Ahmad, thanks for being here for that. So that's my comment. I don't see any comments in the room, and I don't see any comments or questions from fellow commissioners here. So at this time, I would like to invite members of the public to make any comments. Do we have any? Amaniani, we can open up the line for public comment.
Yeah, we have none online or in the room.
None online or none in the room. Thank you. So then I would ask if we would have a motion to,
So moved.
thank you, to approve funding for Fresno and Stanislaus. I'm sorry, for the consent calendar. Thank you, Commissioner Brown. And a second, please. Thank you, Commissioner Mitchell. We have a motion and a second to approve the consent calendar. Are there any questions or comments? Seeing none, then I would ask Jeff, please, if you could.
Commissioner Bontrager. Aye. Commissioner Boyd. Commissioner Brown.
Aye.
Commissioner Bunch.
Approve.
Commissioner Carnavale.
Aye.
Commissioner Carrillo. Commissioner Chambers.
Aye.
Commissioner Chen. Commissioner Cortese. Commissioner Danovich.
Aye.
Commissioner Gordon.
Aye.
Commissioner Mitchell. Commissioner Rolette. Commissioner Tamplin. Vice Chair Alvarez. Chair Madrigal Weiss.
Approve.
Madam Chair, the motion passes.
Congratulations, Fresno and Stanislaus counties. All right, next we will move to agenda item 6, the full service partnerships panel. The commission will hear 2 panel presentations on full service partnerships. As you know, the commission identified FSPs as a priority area for this year. This initial public hearing is meant to provide information about the current state of FSPs across the state through presentations from subject matter experts representing different perspectives. Before we move to the panels, I'd like to invite Commissioner Rolette to provide any introductory remarks.
Thank you, Commissioners. As you all know, the full service partnerships have certainly been presented by leadership of our state as a solution, a part of a solution to ameliorating many of the unique challenges that California experiences today. Certainly, I want to assert that not every person that is homeless is experiencing symptoms associated with a psychiatric disorder. I want to start by saying that because it's important to understand the unique housing crisis that we have in California is not just germane to people who are experiencing symptoms associated with psychiatric disorders or substance use, or it is, again, a housing crisis that cuts across many sectors. However, for the people or the individuals in our state who do utilize full service partnership services, it's important to understand the array of services, the history, and the commitment made by individuals in the state and in the county. Today, you'll hear from Phoebe Bell in Nevada County, who is a wonderful thought leader and a very innovative in how she works in small counties. You'll also, I would be remiss in not acknowledging Dr. Ryan Quist is here from Sacramento County, who has been very supportive of not only the peer perspective or the perspective of people with lived experience, but very responsive to the leadership associated with, again, entities or CBOs that provide much of the mental health or behavioral health service in Sacramento County. My own experience with this has been a bit unique, as like with many of you, my family has been touched by mental illness. During the pandemic, I don't share this a lot, but I lost a son who was navigating the effects of affective disorder and substance use. And unfortunately, at the early age of 38, I lost my son. Me, with all the resources that I had, all the things that I could do, I could not change the trajectory of my son's life. That said, I recognize that the people that I'm privileged to work with are not my family. However, this work is unique, and the work that we do in full service partnerships are unique. The partnerships that we develop with the individuals, again, that we're privileged to serve, and cannot be stated enough, it is a privilege to serve. Those partnerships make a difference, not only in their lives, but in ours. It is important, again, to understand that the workforce shortage is causing unique challenges in that area. We do not have the necessary workforce to do the work that we've been challenged and called to do. Another factor that you will be hearing about today. And then lastly, again, it's important to emphasize data and outcomes, and the fact that there was a commitment to have data and outcomes. And today that a portion of that commitment remains unfulfilled unless you, as a contracting entity, took it upon yourself in collaboration many times with the county to develop data protocols that would inform services going forward. A question that some of you will think about and that will surely be addressed today. I want to say lastly then, and then slightly subjectively, I think full service partnerships work. They work because of the committed work of the individuals that we are serving and the people that are doing the work. My hope is that we not see this as some false panacea that's going to ameliorate every challenge that the state of California has today. But it is an important part of the solution. And going forward, I know that all the individuals that will be presenting today will provide you with not only insight, but help you as you go forward in making sure that the next iteration of the full service partnership document that was expertly presented by the staff of the OAC is again reflective of your sentiment and includes the perspectives of every person in the room. Thank you very much.
Thank you, Commissioner Rolette. Between yesterday's visit and the panels today, I hope to learn more. I want to say something, words matter. And in the last 2 days, just your commitment and what I saw from the staff and from the members, the word members, I think is very important. So not using the word clients, but members, it just really embraces the spirit of everything that I saw yesterday. And those words do matter. It shapes reality, right? Perception and reality. So thank you for that. And thank you for sharing. At this time, I would like to invite Melissa, to our Chief of Research and Evaluation, to introduce the presenters and facilitate the panels. Am I not? I'm sorry, Melissa.
Okay, thank you, Madam Chair. And I just want to echo appreciation to Commissioner Rolette, the staff and members of Turning Point Community Programs for a wonderful and informative site visit yesterday. Just a couple of things before we jump into the panel. As has been mentioned, Full service partnerships are a core investment of the Mental Health Services Act, and counties are required to dedicate a majority of MHSA community services and supports funding to support these programs. As part of the Commission's mission to support transformational change, the Commission has taken on this project to strengthen these essential investments. Today, we're going to hear two panel presentations on full service partnerships. The purpose of this hearing on FSPs is to describe the current lay of the land, to remind us of the original history and promise of FSP programs, and start to identify some of the key tensions, challenges, and opportunities for FSPs within the broader prevention, early intervention, and treatment continuum and broader mental health system. We're going to start the panel with two presenters, Dave Pilon and Michael Robinson. Dr. Pilon is one of the original architects of the recovery-oriented community-based programs that we now call full service partnerships, while he was with Mental Health America of Los Angeles. Dr. Pilon has dedicated his career to the design and transformation of mental health programs, and we are delighted to have him with us today. After Dr. Pilon, we will hear from Michael Robinson. Michael Robinson is a graduate of the Pathways to Success After Homelessness program of Turning Point Community Programs. He is an ambassador of FSP programs and offers a powerful testimony about how these services and supports transformed his life. So with that, I'm now going to turn it over to Dr. Pilon to get started.
Thank you, Melissa, and good morning, commissioners. And thank you, Commissioner Rolette, for acknowledging our deep fraternal bond. I appreciate that. Before I start my formal remarks this morning, I hope you'll indulge me for just a minute to acknowledge the lifelong contributions of Richard Van Horn, who passed away a little less than 2 years ago, who served as a commissioner on this body. None of what I've done in my career would have been possible without the leadership that I experienced with Richard, and he was my friend and mentor, and I know his work in the mental health system of California is known to all of us. But it's important to acknowledge what he did. I was reflecting this morning on the fact that it was 34 years ago this week that I was in front of a computer finishing up the proposal that created the Village Integrated Service Agency under AB 3777. And for 3 weeks, my first 3 weeks working at MHA, it was like 16-hour days. I'd go home and I'd sleep a few hours, and I'd come back and I'd go to work for 16 hours writing this proposal. And I was writing it with 4 people: Richard, Ann Stone, Joe Ruiz, Julia Scalise. Did I get everybody? And Richard, yeah. None of them had any sort of formal training in mental health or mental illness. I was the only person who had that kind of formal training, but they were trying to create a program based on what they had already done with in smaller scale out in the community. And I realized in that moment that I had joined a cult. It's like a cult of seeing people for all the potential that they had, regardless of whether they had a mental illness or not. Fortunately, we were, I'll get into that story, but we were able to get it. But without Richard's leadership, without his constant devotion to bringing, services to people with severe and persistent mental illnesses, none of this would have happened. So I just want to acknowledge him. I feel like I'd like to think that he's in the room with us today, and as I deliver my more formal remarks. So thank you for letting me share that with you. Could I see the slide presentation? So I titled this Back to the Future because it feels like every 30 years or so I'm reiterating the same components of the original. This is sort of our village origin story that I'm going to share with you today. Oh, thank you. Appreciate it. So what you need to know is that the village was formed out of Assembly Bill 3777. And the original bill said there was going to be an urban project, a rural project, and a countywide project. And Merced County got the rural project. We were the urban project, and Ventura County was the overall county project. But one of the major features of that original pilot was that, and I can't emphasize enough how much of a difference this makes, it's that we would get $15,000 per person per year in advance and no required Medicaid billing. We were going to be judged on our outcomes rather than by any particular services that we provided. We won the proposal. It was a statewide open proposal. And it took us a little while, but we opened our doors on July 1st, 1990. And it was unusual in the respect that you hardly ever see this in community mental health services, is that 120 members were randomly assigned to the village, and by the way, I use the term members as opposed to clients or consumers. They're pretty interchangeable, but that's just the background that I have in terms of the way that I talk, is like members of our community kind of thing. So 120 members were randomly assigned to the village, and 120 members were randomly assigned to a control group. And you never see that in community mental health, but the random assignment allows us to actually make conclusions and draw inferences from the effects of the services, of what village members got versus what the control members got. This is also very important when we talk about what the village consisted of. It combined two models of delivering services: the assertive community treatment model and the clubhouse model. Both of those were essential components. And as I'll explain later, I think that people tend to forget. We think it's all about assertive community treatment, and that's an essential component. But people forget about the essential feature of including psychosocial rehabilitation services, which are sort of embodied in the clubhouse model. As I mentioned before, it was a full risk capitated model. So we were responsible not only for the services that people were receiving in the community, but also for their hospitalization. So if somebody went into the hospital, we were on the hook for that cost. And as I'll show you later, that actually incentivized us to reduce the costs of, reduce the use of hospitalization as much as we could. And we employed a lot of staff, licensed staff, as you would expect, social workers, psychiatrists, nurse practitioners, but we also employed a lot of non-licensed staff, both at the level where we would talk about things like job developers or job coaches, but we also had a lot of BA level staff who were what we would call community integration specialists, those kinds of positions. And those were oftentimes positions that could be filled by peers as well. And the final bullet point there, services were designed to address all aspects of the member's life, not just the symptoms of their illness. Oh, that's pretty small type, sorry. So the independent evaluators findings after 3 years, we actually were under the state funding for a 6-year period, but the study went for 3 years, where the independent evaluator was doing interviews with family members and with the consumers, with the members over that 3-year period of time. And these were the primary results that they found. We had significantly fewer hospital days, for example. And the interesting thing about that is that we didn't reduce the pure number of hospitalizations that much, but the length of the hospitalizations were shorter, because we were able to get people out and get them back into the community a lot faster than the folks in the control group. And this is probably, to me, the most significant result that we saw, is that nearly 3/4 of the village members at some point during their that 3 years, they actually tried employment. They got a job. Now, not all of them, kept a job during that time, but that was compared to, what was it? About 15% of the folks in the control group. So we got about 5 times the level of employment results that we did, that they did in the control group. And I won't go into much of the other outcomes, but I will, point out that, village members reported more solitary leisure activities. They were having fun both alone and out in the community than people in the control group, and they were more satisfied with their mental health care. So people sometimes ask me, well, what do you think was the reason for these differences between the treatment group and the village and the control group? And I point them to this chart and how we spent the money in our budget. We spent about 40% of our budget on what the independent evaluator called case management. I prefer the term care coordination. As Commissioner Roulette pointed out to us yesterday, people are not cases and they don't want to be managed, but we do need to help them coordinate their care. It's like, this is one of the essential components of FSPs, because the people in FSPs are often not able to independently coordinate their own care. And this is the essential service that we offer in FSPs. Commissioner Roulette is right. FSPs work because that's what they do. Okay. So we spent about 40% of our budget on that versus 10% in the control group. Day treatment is essentially the same, medications essentially the same, residential essentially the same. Then we spent about a little more than 10% of our budget on socialization. And you'll see the telling thing is that the next line is outpatient therapy. We only spent about 5% of our budget versus 23% in the comparison group. So folks in the comparison group were getting a lot more therapy. People accuse me of being anti-therapy. I'm not anti-therapy. I guarantee you, I benefited from therapy myself. Okay, but the point is, what do the members want? It's like, are we making the determination that it's therapy that's important, or are they? And what we found is that not that many of our members were that interested in therapy. We certainly would give it to them if they wanted it, but they were much more interested in the socialization and vocational aspects. And that will, you will see, points out the enormous difference between what we spent on what I use the word employment for, but the evaluators called vocational. Literally 25% of our budget went for employment services. So it should be no surprise that you get what you pay for. This is why we got the employment results that we got, because we were investing our resources in that. We spent a lot less of our, excuse me, a lot less of our money on acute hospitalization, as we were getting people out of the hospital faster, and we spent less money on long-term care. So about 4 years ago, I wrote a proposal on behalf of LA County to create a pilot project in your innovation category for Hollywood. It was called a Trieste proposal. Some of you may remember that. And this is a design of what the service system in Hollywood was hoped to look like based on this pilot proposal. And the feature of this that I want to show you is that when we designed this, we moved those psychosocial rehabilitation services up to the top of the grid. You'll notice that full service partnerships are in that row, second row, represents our current mental health outpatient sit-in system, from drop-in centers on the left and clubhouses to full service partnerships on the right. And the fact is that there's no current equivalent of psychosocial of a funding stream for psychosocial rehabilitation services. They're sort of expected to happen under full service partnerships, but I would make the case that this is the part of the model that has been lost in translation to some extent. And so when I designed this proposal 4 years ago, I said, well, I'm gonna pull those out and I'm gonna put them up on the top because these are the services, psychosocial rehabilitation services like supported employment, supported education, community integration. These are the things that give people or help people to achieve purpose and belonging. It's like, yes, care coordination is essential. It helps people to manage their lives, but it doesn't help them to find purpose and belonging in their lives. And so if it's going to stay in full service partnerships, that's fine. But there has to be some way of ensuring, because there isn't a tradition in all mental health agencies of psychosocial rehabilitation. Many are come from a very much more, it's a psychotherapeutic background. And it's not that they're against psychosocial rehabilitation services, but they feel like they're ancillary in some way. And if there's one argument that I would make, it's that we have to push those up to the top of the grid and say, these are primary. These are the things that people need. And that we can't have a successful system unless we offer these kinds of services in a much more robust way than we currently do. And so these are some of the reasons why I think that we aren't providing them. Is like, if you have one person in front of you who's saying, you know, Dave, you know, you've been talking to me about going back to school for like 6 months, and today is the day I'm ready to do that. And you have another person at the same time who's saying, you know, Dave, I'm about to be evicted from my apartment. Who's going to get your attention, kind of thing? It's the person who's about to be evicted from their apartment. And so we have to have a system that actually dedicates staff and dedicates resources to these kinds of much bigger services that are focused on people's purpose and belonging. The other thing I'll mention is that our current Medicaid system puts up significant barriers to billing for these things. I have been a big advocate for many years for going to a pay for performance model where we actually pay for the outcomes of services. That's essentially what the village was. It was we were not expected to do any kinds of billing on the minute by minute basis. We were just expected to get the outcomes, and it really frees you up to do a whatever it takes approach, because you don't have to worry about am I going to get audited because I went and talked to a businessman out in the community for an hour about hiring one of our members. That, to my knowledge, is still not billable under Medicaid, even under CalAIM or something like that. So unless we address that issue, we're gonna struggle with providing these kinds of services. And so the other issue is that we just don't have the staff to who are trained to provide these kinds of services. So these are my recommendations. Explore a true pay for value or pay for performance system that holds providers accountable for their outcomes. And this would have the effect of reducing documentation and billing burdens, provide separate funding streams, decoupled from FSPs if we can't ensure that they're happening in FSPs for psychosocial rehabilitation services like supported employment, and increase the hiring and reliance on non-licensed BA level staff. As Dr. Rolette mentioned in his earlier remarks, there is a staffing crisis out there, and we are never going to have the number of licensed staff that we need to provide all the services that we do. But we can, if we focus on services that don't require a license, we can find a lot of good BA level staff. We had wonderful BA level staff who could provide community integration services at the village. And we need to move back in that direction. Thank you for attending. Yeah.
Great. I think we can turn it over to Mr. Robinson for your presentation.
Thank you. Good morning, everybody. Good afternoon. My name is Michael Robinson. I'm originally from San Francisco in the Bay Area. Came up here about 17 years ago. I lost my wife in 99 to brain cancer and lost everything. My whole world just fell out. Whole floor was pulled out from under me. I came up here looking to turn my life around and got back involved with the alcohol, not the drugs, but the alcohol, and was staying out in Discovery Park for about 6, 7 years, homeless. Tried to commit suicide, went to Schmick. A young lady from Crisis Residential named Leslie Springer came and talked to me. She said, "You don't need to be here. You need to come to our house." So I went to the house, the Turning Point Crisis Residential House. I stayed there for 90 days and I left, went through it. They got diagnosed and didn't know I had a mental illness, but they told me I did. I got diagnosed, got put on medication and left the place. But I was still homeless. Ended up going back 3, 4 different times, 4 more times to Crisis Residential because I didn't know what to do. The only way I saw was just killing myself. They told me, no, there was another way. And I told them, I said, I just need a place to stay. 1 week later, Turning Point had me in a 1-bedroom apartment in the Thomas. I stayed there for 1.5 years. They asked me to move to Boulevard Court. Boulevard Court, I love it now. When I first got there, I didn't. It was real small. I had to get rid of some of my furniture because it couldn't fit in the room. But now, I mean, it's my home. It's my community. Everybody in there I love. They don't all love me, but you know, it's his home. If it wasn't for Turning Point, I'd have been a statistic here in Sacramento. They pulled me out of the quicksand. They tossed me a lifeline and I grabbed onto it and pulled it out. I jumped off the pathway. They put me right back on the same pathway I needed to be on. I came to a turning point in my life and they were there to help me. I thank all of them, all the staff that I've dealt with Turning Point. They've all been there. Anything I asked for, they've done for me. I've had a stroke when I got in Boulevard Court. I was there about 1.5 years. Ended up, doctor told me if I didn't stop drinking and abusing my medication, I was going to have a stroke. And I didn't think it was going to happen. I'm a Marine. I did 6 years in the Marine Corps. I'm tough. I can fight this stuff off. You know, good enough, it whipped me up. I came to 2.5 months later in the hospital in Carmichael and didn't know what had happened, didn't know where I was. And the first person I called up was Renee McCray, who was my caseworker. And she was in Washington State. And she asked me where I was. I told her, I said, I didn't know. And the next day I gave her the phone number where I was. I found out the name of the place where I was. And the next day, one of the caseworkers were up to see me and from Turning Point. And 2.5 months out, no way. I just felt like I slept and woke up the next day, you know. But it was true. It was true. Turning Point paid my rent for 2 months, which was a blessing for me. I didn't want to lose my place. They were talking about I was going to have to go to a board and care, and I told them, no way, I'll show you I can take care of myself in my own apartment. So I did the physical therapy and occupational therapy and showed them I can put things on the shelves and stuff like that. And then let me go back home. Like I said, if it wasn't for Turning Point and Pathways, I don't know where I'd be at today. I'd probably be, like I said, a statistic today. They pulled me out the quicksand, and I thank them every day. I would do anything and everything for Turning Point Pathways. Thank you.
So this is the end of our first panel. So I think we are open to questions from commissioners.
I just had a comment. If you guys can hear me.
We can hear you. Go ahead.
Okay, I just wanted to thank you both for your presentations and agree with what you were saying about how important the psychosocial rehabilitation services are. I agree, it's unfortunate that often it seems like this is such a small part of treatment and services and typically done by case managers, and we never have enough case managers. So it's just something that we're not able to provide for our clients. And I agree, a lot of time that has to do with billing because those aren't billable services. I just wanted to agree with that. And then, mention that unfortunately, I think that this is going to get worse with what we're hearing about payment reform, but just really emphasize how important that those services are. And again, thank you both for your presentation.
Madam Chair. First a question and then a comment. My question is with respect to Dr. Pallion. And it's amazing that you spoke about the Trieste model that you worked on and that was put into place, because I was actually talking about it this morning with Commissioner Chambers as we were driving over here. And we were talking about the situation in downtown Los Angeles and how years ago we had a meeting in downtown LA, and I'd driven in the night before and driven through Skid Row and just saw how terrible it was in terms of the situation with so much misery that was down there. And we had a presentation on the Trieste model and the pilot in Los Angeles that was done was it Hollywood or West Hollywood? Was it Hollywood? And the mental health director, I asked him, I said, why are you doing this in Hollywood and not doing it in downtown Los Angeles? And he poignantly, I think, said, well, Hollywood has come together as a community and they bought into this concept and what have you. But he said the real reason that we're doing it there and not in downtown Los Angeles is because we wanted to have a chance of success, that the magnitude of the problem in downtown was so great that it was, almost impossible to do. But can you tell us the results of what happened? I understand that it wasn't entirely successful in Hollywood, and what were the barriers and what happened there?
So first of all, Commissioner, my understanding is limited in that I wasn't part of the discussions, but as the commission will remember is that LA County came back to the commission and asked for changes to the original proposal, because originally it was to be completely innovation money funded. There was no Medicaid match involved. And my understanding is that LA County thought about that and said, well, we can't afford to leave that Medicaid money on the table. But that's just speculation on my part. I need you to know that. And also the pandemic hit about the time we were trying to implement it as well. And so that caused a lot of chaos as well. But now the county is moving forward and they're trying to, as best they can, to implement many of the original parts of the proposal as possible. And we're even, talking with the county about carving out a little piece of that original proposal and saying, just give us a little bit of it, 5%, 10%, something like that, and allow us to do it without the Medicaid match and see what we can do, see if we can get the outcomes and if that makes a difference kind of thing. So we're talking with the county about what that would look like and are we going to do it. But just so you know, we're still in the community engagement process. So we're, trying to get that moving, but the pandemic just, destroyed the timelines on that completely. Yeah.
Thanks. And then a couple of comments, actually. First of all, Mr. Robinson, I appreciate very much your comments and courage in coming in here and telling us about the journey that you've had and the success that you've had and the wonderful work of Turning Point. And you are a shining example of the proof that recovery is a process. It's not an event. And, there's so many people that get frustrated by, we want the quick fixes and the quick solutions, just like changing TV channels in America. And sometimes, as in your case, it takes a while, but you've come a long way, and we appreciate you coming today and sharing that with us. And then to Dr. Pylon and his comments, particularly about the village and Richard Van Horn. I have the dubious distinction of being the senior member of the commission at this point, and worked very closely with Richard and was an admirer of him as well. And I just want to say that you did him proud today, and you do. The village concept is really something that's amazing, and you've left a great legacy for him. So thank you.
Thank you, Commissioner.
Just a quick comment and then a question. First and foremost, Mr. Robinson, thank you for being here and thank you for your service. I really do mean that. My belief, Dr. Pylon, what you said around some of the psychosocial rehab activities are pretty critical. I think we have a crisis of culture as much as we have a mental health crisis, and that sense of belonging. But the question I have, you talk about community integration activities and services. Can you further elucidate that? What are some of those?
I'm so glad you asked that question. It's anything that's trying to reintegrate folks into the communities that they may have lost because of the fact that they have a mental illness. So somebody would love to go surfing. Somebody wants to be in a band. Somebody wants to, whatever it is how do we help them to achieve those kinds of things? At the village, for example, we had a member staff band. It's like members and staff playing together, and they would actually go to clubs and play it at clubs. We got into ethical dilemmas. It's like, well, they're serving alcohol at clubs. Should we really be doing this? It's like, the name of the band was called The Delusions. Okay. And I'll give $5 to anybody who can tell me what their backup singers were called. You have 5 seconds. The Auditory Hallucinations. Okay, that was their backup singer's name. Okay, sorry. But activities that they're the more formal things like supported education, where we're actually working with employers out in the community. But what I've found is that helping people. I happen to be a thoroughbred handicapper. I like watching the horse races kind of thing. I once took a group of 10 members to Hollywood Park to bet on the races. Okay, now everybody's gonna say, what? On their SSI? Well, it's $2 a race. It's like you don't have to worry about that. And the interesting thing was, it was because I was interested in it and I wanted to share that passion with the members, but they, none of them were that taken with it. By the end of the 4th race, they were saying, this is kind of boring. Let's go home. It's like watching horses run around a track. That's fine. But it's the exposure. It's helping people to find sort of like what makes them passionate, what they care about, what their sense of purpose and what their sense of belonging is. And it can be formal things like education and employment. But I also think that on the Hollywood project, for example, we've got these great resources like the Hollywood Bowl, taking people to the Hollywood Bowl and exposing them to music and those kinds of things. There's lots of people who would like to do those kinds of things, but we don't offer those kinds of things. And I realize that this is a heavy lift on some level, because we're always, as I was saying earlier, focused on the latest crisis that people are experiencing. And that's why you have to have dedicated staff whose job is not to deal with the crises, but is to deal with the purpose and belonging needs that people have. Does that answer your question? Yeah.
Thank you, Chair. First of all, Mr. Robinson, thank you for being here. I thoroughly enjoyed meeting you and your dogs yesterday. It was a highlight. Dr. Pylon, I was equally enjoyed interacting with you yesterday, and I was really moved by this thought. As someone who's not in the system of mental health or even really in government, I think many of us, know that there are lots of needs not being met and we don't really understand why. And so housing is such an easy one to grab onto because most of us are lucky enough to have houses, and it's hard to fathom how somebody operates without a house. But there is this kind of illusion. I really realized this yesterday that we think, well, if we give somebody a house, that's enough. But I learned yesterday it's not nearly enough. And I was really moved by this idea that we need to change the outcome. We have to move to an outcome system, and these outcomes need to be around belonging and purpose and measuring how many people make their way through this recovery process to education, to employment, to being productively engaged in their communities. And I think that's a powerful idea. But my question for you is this: I look at the January Mental Health Commission report on full service partnerships. And one of the things it clearly says is, despite regulatory requirements, counties do not appear to be allocating mandatory minimum funding levels to support the FSP program. So I'm wondering why. How can they do that if it's a requirement? And why are they not doing it? I assume it's not because they don't think it's a good idea. It clearly delivers needed results. So do you have any opinion about why counties are not adopting? Is it just too hard to do? What is it?
As I said, I think that the crisis in our face gets all of our attention and doesn't allow us to focus the resources on these other things, because there's always a crisis around the corner. But as I'm sorry, I don't know, Commissioner, to your left talked about a crisis of culture. A crisis of culture, because I think that we have to get this idea out of our mind that these other things are ancillary. And that's why I put them up at the top of that grid, is we have to remember that is the aim of services, not just getting people to sort of where they're quote unquote stable or maintaining them at a level of stability, but moving them on in their recovery where they can achieve normalized roles in the community, kind of thing. But it's hard because there's always another crisis that's going to be, pulling at your purse strings, kind of thing. Yeah.
And so why is it not being adopted more? I get that we're not getting the point. But why are counties not adopting this more?
Commissioner, it's the crisis mentality. I think that's what
it's just the mindset.
The mindset, the culture, the service culture is that just get people stable. And I'm glad you mentioned that, because when we created the village, I have to admit to you that I was in that same place. It's like recovery wasn't even a concept that I was considering when we wrote the proposal back in 1989. I thought, these people are going to be with us for life, kind of thing, and they'll never truly be back in the community, and we have to provide a really good service for them. But what we quickly discovered when we provided this kind of thing is like, folks are capable of a lot more than we originally thought. When you hear somebody like Michael's story, you think, okay, now I get it. And, as inspiring as your story is, Michael, I've seen it many times. Many people can do this if they're given the kind of support that Turning Point provides, or, the village provided, or those kinds of things. They can do that. But part of the problem also is that, as Commissioner Rolette said, FSPs are working. We just don't know it because we aren't reporting our outcomes. So it's happening out there, but we aren't. Why aren't we hyping this? Why aren't we talking about this more? When Michael has a success, it should be part of this data gathering where we can actually show, yes, we've had many people who no longer haven't used the hospital in years, or haven't been to the emergency department in years, but we don't have those data to sort of reinforce that with folks. And so, the media being as outrage focused as it is, it's always on the latest crisis that we've had. So I don't mean to I hope you don't think that I believe that FSPs aren't working. They are. They're creating great results, but we're not putting that out there.
Yeah, I just redouble our efforts as a commission to elevate this work more and to work even harder to get counties to adopt it. Thank you very much.
Please, Commissioner Roulette.
Wanted to acknowledge the issues associated with the workforce challenge that many of us have referenced and talked about. And in particular, Michael, again, thank you so much for sharing your story and your life over the years and allowing me to engage you in a way that is really in keeping with all the things that we hope to accomplish in the work that we're doing. I would be remiss and to state that Michael and I don't always agree on everything. He's a 49er fan and I am not. That said, I understand the importance of having the workforce available to you when you need it. Renee McCray, who Michael references, in the audience, and she took the phone call while she was away on Washington that Michael made while he was recovering from his stroke. It is essential. The workforce challenges are compromising our ability to do that, to take those very important phone calls when they are made. And don't miss that point. She was not in California. He was not in the community. But that was that point in time where you really need someone to pick up the phone. And that's what full service partnerships are designed to do, to have staff available 24 hours a day, 7 days a week. The other point that I want to make about Michael, that is, again, an acknowledgement, Michael, of who you are and your commitment, your zeal to continue to give back. Michael is not dependent on specialty mental health services any longer. And that's the goal of full service partnerships. So people are not dependent on those specialty mental health services throughout the totality of their lives. And as Dave said, naively, initially, 32 years ago, he thought, okay, that's the way it was going to be. But it's not. That is not the way we operate. We operate in hopes to support people with flourishing. And so for you, Dave, my question is about flourishing and flourishing scales. And I don't know if the other commissioners are familiar with those. I've been a proponent of flourishing scales as an important outcome measure that is reflective of the perspective of the individual that is receiving the service. If you could say something about that.
So I'm unfamiliar with flourishing scales. Sorry, Commissioner Roulette, but to me, the particular scale is not as important as but that we measure our outcomes, is that we decide what it is we're going to say, and I'd be happy to look at those and evaluate them and say, does this capture what we're hoping to achieve with our members? Because I agree with you 100%. The idea is to graduate people from mental health services. And I know that for a lot of people that sounds fanciful, but it's not. It's like people recover all the time and they don't need the intensive level of services that FSPs provide. But we have to have a metric that allows us to determine that. And if flourishing scales are part of that, that's fine. I'm a little I have a penchant for my own scale that I created, but that's okay. It doesn't have to be that. It just has to be some metric that we use to figure out where people are and that it's valid and reliable. That's all I care about. Yeah.
And I think that, Toby, my assertion is that we do need to support the scales that really do reflect that we are gathering the data and that we are actively querying the perspective of the individual receiving the services. I'd also be remiss if, Dave, if you feel comfortable saying something about community-defined practices, because there's this, again, it was stated earlier by Stacy, we support community-defined practices, especially those practices that work in communities where individuals are unserved or underserved and have been successful, but potentially are not evidence-based because a variety of things.
I'm completely in favor of community-defined practices as long as they are in the process of providing evidence for their effectiveness. That is the important criteria for me, is that we have to be evidence-based kind of thing. But obviously, if there are starting up that they don't have the evidence, and so we have to give them the time to develop the evidence as they work their process. But at some point, you have to look at every practice and say, is it delivering on its promise? But
And then my last point is about like back to you, Michael. I won't ask you to repeat the story, but there was an event that Michael intervened in. Michael referenced in passing. Not everybody at Boulevard Court likes me, except Michael did something that every citizen should do. There was an intruder that came onto the property of Boulevard Court. One of the residents at the apartment complex had their door open. The intruder went into an open door. And when Michael and the management of the Boulevard Court property intervened, they found the intruder getting ready to commit a crime, a serious crime. And without Michael's intervention, who knows that if that would have been interrupted. And it is because of you and your citizenship and your commitment to that community that you changed that person's life. And I want to acknowledge that and applaud you. And that's what flourishing is about. You are a part of a community, you're invested in the community, and you change the experience of your community because of your leadership. So thank you, Michael Robinson, for being a leader. Thank you.
Just a brief, just a brief addendum. I'm compelled to point out that because you mentioned flourishing, it is now in business best practices, HR cutting edge, to be looking at wellness and flourishing as scales that are trying to be accomplished in the private sector. And the fact that we're still debating and even discovering that they should be outcomes in the public sector points to this huge equity gap between public and private that needs to be addressed.
Thank you, Commissioner Carnevale. On that same thought, I wanted to go back, if I could have you, who's handling the slides? Because there's a slide that I wanted to reference. Yes, please. Back. One more, right there. So as I look at this, you know, I'm in schools, so these are discussions that we have. When I look at the scales and I look at, or the numbers, and I look at the village, where the emphasis is really in those categories that I consider holistic, right? The whole person. So in schools, it's the whole child, but it's the whole person. I think about the flourishing. I think about you're addressing those things that bring hope and belongingness. You're addressing that whole person's life. And when I look at the comparison, I don't even see where a human person is being, right? It's the illness. And so that, to me, where is our current practice, would you say? Is our current practice more in the comparison group, or are we more in the village?
Wow. I think it varies tremendously across the system. I think that depending on I think FSPs are probably further towards the holistic than other parts of the system. But to reiterate the point earlier, it's like it is a culture issue, is that focusing on some level, I feel like we're the victims of our own success, because in talking about recovery, we created a language where people talk about recovery, but they don't necessarily practice it. And they have the words for it. And we say, of course, we're recovery oriented. And then we ask them, well, but how many, staff are focused on helping members to get jobs? It's like, well, we won't really have the staff for that, or those kinds of things. So it's really the power of that slide, I think, is that it really says that you have to put your money where your mouth is. It's like you can't, it's not just about saying that you're in favor of recovery or recovery-oriented services. It's like, do those services that you provide actually focus on those kinds of things? And it's not that people are intentionally, not being holistic. They just don't know how to do that. And because we don't have a culture of psychosocial rehabilitation. And Commissioner Carnevale was asking me, well, why don't we have this in California? It's like, and I should have said to you yesterday, it's like, it's not that prevalent anywhere in the United States. There are places where it's more prevalent. Psychosocial rehabilitation actually started on the East Coast, and it was focused at Boston University and that kind of thing. But there have been places that, that have adopted it, but it hasn't been adopted, widespread anywhere in the United States. And so what I'm asking you all to consider is like, well, should we be thinking about ways to make that a more significant aspect of the way we think about services? And I think that people will embrace it, but they have to be given technical assistance and support in terms of moving toward that system. Yeah.
Please.
Good afternoon, morning still.
Morning.
Michael, thank you for your presentation. Beautiful, totally touched my heart. And Dr. Fallon, I was also looking at that same slide. And so to kind of discuss that point on the practice of why the holistic model is so much more successful looking versus the comparison group. And also to my colleague's question, it's the why. Why isn't the dial moving towards some of these more basic practices that give us these types of outcomes? And I think a lot of it is, it's this draconian thinking in the past of only one thing works, or we're looking at Michael as, how can I say this? Let me go back because I'm having a lot of thoughts. So right now in California, we're investing a lot of dollars in family finding. So why are we doing that? So I'm in children's health. So we are doing that because a lot of our children who are removed, the system says they're taken from really bad families and they shouldn't be put back with these bad people. Well, evidence says that's not true. I have a 5-day-old baby just the other day, Friday, that was removed from their parents. So the system cannot give that 5-day-old what their mom would give them. Again, the thinking is, let's remove this child for many reasons. But at the end of the day, that child still needs to have some type of bonding with their mom. But this old way of thinking, it doesn't allow us to practice practical matters that really help. So I guess my question or comment is, how do we get there? How do we change? Because that's what it appears that we need training, education, very smart people to somehow develop a system thinking change, because that's really the answer to this question. So what is your suggestion or thought? How do we get there to change the thinking to help these models improve, or to those individuals who are doing the work? How do we get there? I mean, that's a big question. I'm sorry I went kind of all around it, but I'm just having so many thoughts on it, because really it just comes down to changing the thinking.
It is. It's a culture shift to a large extent. So how do we help the culture shift?
How do we get to this culture shift? If the change had not occurred with the thinking that Black Americans should be free, or that slavery shouldn't have ended. It's how do we get there? Because those are big tasks, but as
There-
you see, they affect people like Michael in such a major way.
Exactly. So as I pointed out earlier, the way we pay for things has an enormous impact on what people feel that they can do, whether it will be reimbursed. And I can tell you that Medicaid does not make it easy to pay for things like employment services. If you want people, I think I mentioned earlier, if you make it easier for people to actually bill for these things or provide these things without the fear that they're going to have the money taken back, then they will do them. I don't think people don't want to provide these kinds of services. It's just that they feel like their hands are tied. It's like that the federal government will take back the money that we pay to do that. Yesterday, Commissioner Rolette was talking about the fear that all provider agencies have, that 5 years down the road, the feds are going to come in and say, oh, by the way, you shouldn't have provided that service. We're taking back $5 million or something along the line. And the risk management that requires for a provider, it's terrible. I can tell you, it's like, it killed me. It's like, when I think about that, it's like, okay, retirement isn't so bad. So it's not that people don't want to do these things. We have put up roadblocks that make it very difficult, if not impossible, to do them. And it's all about the way that we pay for mental health services. I think that's a huge disincentive to providing that kind of culture shift. You're also right, though, is that we have to provide them with the training and the understanding of how this can work. But I'm a believer that, if people were to actually, it was a shock to us. I have to tell you, back in the early 90s, when we saw how people could thrive and flourish if they were just given these kinds of services, none of us from our own experience could imagine it to the extent that we did. And we will see the same thing, but we didn't have those financial impediments that currently happen. And I can tell you, it's like in the 1990s, we had people coming to the village all the time for what we called immersion trainings, and they would look at what we were doing, and they would say to me, because they would say, well, we can't do this under Medicaid. And in my arrogance, Commissioner, I thought, oh, come on, it's, what's the big deal? It's like, you can do this. It's like, and then on July 1st, 1996, the state of California said to us, you're done. This was great. We're so glad we funded you and you approved this model works. Now we're putting you under the Medicaid system. And we had to then start billing for Medicaid. And I cannot tell you how that tended to undermine the culture that we had created for 6 years. And it was the rest of my career until I retired. It felt like I was fighting a constant battle to hold on to the culture that we had created under this new billing system. And it was really hard. Do I feel like we managed to hold on to it? Yes, to a large extent. But it was so different from that first 6 years because staff were spending 25 to 30% of their time documenting now instead of going out and going to having a band at the local bar kind of thing. It's like, so that was kind of diminishing it. I really felt like there was a huge difference that happened at the time. And if I sound like I'm being a broken record on this, it's like the importance of how we pay for things is just a critical component of whether the culture can make the changes that we would like to see. Yeah.
Thank you. Commissioner Bunch.
Thank
is
you.
on- Please.
I just wanted to say, I supervise at a very large clinic in LA County, and I do think that the staff are there. Their thinking is already there. The workforce they think in the same way, but people are only allowed to do what they can do, right? So much of it does have to do with the billing. So if I'm at a clinic and if I'm at the clinic today and I hospitalize someone and it takes 4 hours, I can bill for maybe an hour of it, right? Because it's face to face. So on top of that, when we talk about, looking at that difference in the graph and looking at even just hospitalizations for so many of our staff who, again, they are a shortage in the workforce, by the time they've kind of gotten one person stable, there's another person who they have to help get stable. So I think that really attributes to what we're seeing in the increase in the hospitalization on the other side of it. But if there is any way that the commission can address these things, I agree with everything that is being said. I just don't know how we go about addressing it.
Thank you, Commissioner Bunch.
So we keep hearing about billing and we heard that yesterday. Is that something have we taken that on? Is it something that's possible to take on? Is that something we should put on our to-do list here?
That would be a question for Mr. Ewing.
Yes, Toby, let's take it on.
Thank you, Commissioner. The intent of this first hearing, the site visit yesterday and the hearing today, is to create some education and awareness and identify lines of inquiry. So absolutely. The commission is required under the law to provide a report to the governor and the legislature every other year. And so we wanted to make sure we did the report that is included in here. That was more sort of a game plan report because we only had a couple months to draft that. But this really is a chance to identify questions. Staff are documenting, taking notes, and we will then develop a game plan to follow up. The second panel does include FSP providers, so a provider and a county leader. And so these are the kinds of questions would encourage you to bring up during the second panel as well. Thank you.
Thank you, Toby. So at this time, I'm going to ask Melissa to introduce our second panel. And Dr. Pullen, let me pronounce this correctly. Pullen. I'm going to ask you if you wouldn't mind just staying there. The next panel is online, so maybe there's questions afterwards. And Michael Robinson, please, if you'd like to stay there too as well, that would be great if you're comfortable with that. And we appreciate your presentation. And so we'll listen to the next panel and then just see if we have a discussion thereafter. That's okay. Thank you so much. Melissa, please, if you'd like to introduce the next panel.
Thank you so much. So our second panel will now bring in perspectives from a provider, a county mental health director, and a capacity building and technical assistance partner from the multi-county collaborative on full service partnerships. So I'd like to first invite Lisa Cepeda, who is a licensed marriage and family therapist for Kingsview, working in Kings County. Ms. Cepeda has worked in her community for the last 12 years, and again, we'll be sharing insights from the provider perspective. She's also joined by Fallon Martinez, who is a certified Medi-Cal certified peer support specialist at Kingsview, and she's here to share her perspective as a peer and discuss their role within FSP programs. So Lisa, I'll pass it over to you. And thank you so much for being with us today.
Thank you, Melissa, and thank you everybody online, and we're not in person, but thank you for the invite. We also have David Palunas. He's our executive director for our behavioral service line, so I wanted to also introduce him and his support of him being here. I like to thank you for the opportunity to come and speak and share about our FSP program. We are located in Kings County. I do have a PowerPoint, so give me a moment just to set that up. I know I can share my screen. Sometimes I get a little confused with that. So hold on just a moment. All right. Can you guys see this? Can someone just say, yes, I can?
Yes, we can.
Awesome. Thank you so much. So again, my name is Lisa Cepeda, licensed marriage and family therapist. I am part of our Kingsview organization, and I'm a program manager here at our Hanford location. Hanford is located in the Central Valley, about 45 minutes south of Fresno. I always like to give that description because not a lot of people may be familiar with Hanford. We're really part of a rural community, even further than Fresno. But when I say Fresno, sometimes it gives people an idea of where we're located. So a little bit about who we are, if you're not familiar with Kingsview, is we are a nonprofit organization that was founded in Wrigley, California, and we're located in Central California since 1951 by the Mennonite Central Committee to address the need for treatment of mental health. We have a variety of different behavioral health services that are provided within our organization. Anything from, we have a co-responder triage program for crisis in our Fresno County area. We provide outpatient direct services like with therapy in Tulare County, and I'm located in Kings County. And so I'll be speaking from our full service partnership that we have set up in our Kings County program. And like I said, I'm out of our Hanford location. However, we provide services throughout the county. So different areas such as Avenal, Kettleman City, Lemoore, and Corcoran, if you are familiar with Kings County at all. I put a little map on the screen just to kind of give you more of an idea, more or less where we're located, as well as our county and city symbols. And so I'm really excited to be here. I was not born in Kings County. However, I have been raised and very familiar with the community. So when I went off and got my education, it was a great passion to come back to the community. It is considered a hard to fill area when it comes to clinicians. And so to be able to bring back what I have learned and serve my community, I have a dual passion, not just for my excitement to be a clinician, but also to be able to serve the people in my community and in my county. And so there's some ownership to that, which I think helps a lot with my passion and the sustainability of me being able to serve in this program. I did start as a team lead. So in about 2019, the county, we are a nonprofit organization, and we are the contracted provider for adult services in Kings County. And in 2019, or a little prior, but I came into this program manager position in 2019, I was tasked with taking our adult population, which was about 600 or 700 consumers at the time, and was tasked with being able to separate out from what we call different levels of care. So that was for specialty mental health services, our county named the different levels of care, with recovery oriented being at our lowest level, but still those who would qualify for specialty mental health services. And then we have our full service partnership level. And then at the very highest level of need is we do have an ACT team, which is provided, those services are provided by a different provider altogether. So we are a fairly newer program in FSP. So with each year, we have our own set of goals that we're trying to make as we continue to refine it and improve our approaches and services for our members. So just want to focus on the full service partnership level, because I know that's what we were invited to talk about. So for us, the way we view it, and usually how we try to explain it to our members or other community partners, or even different staff who's in our shared building, but they're in different departments, we try to give this information. So we basically tell them it's a program that it's for increased services. It's like a wraparound approach, and really trying to focus on individuals who are at risk of institutionalization. They're homeless or at risk of being homeless. They are constantly maybe finding themselves in that revolving door of the criminal justice system. or have been incarcerated or coming out of jail or the prison system, or who have a high frequency of use of psychiatric inpatient services or access or crisis episodes. So the way we refer into FSP, it's often clinician referred, but it's not just by our clinicians. It can also be from various community partners, such as the jail, our local human services agency. Those are some of the common ones, just to give an example, the superior courts. So we get referrals that come through to us for individuals who have been identified to fall in maybe one or more of these areas. And so the focus of FSP is to, like I said, provide more intensive services, including frequent contacts from our treatment team, which is made up from a variety of different staff members that I'll go over in just a few minutes. But the focus is targeted interventions to help reduce or eliminate those risk factors and really focus on stabilization efforts. So that's just an overview of how we try to describe it to individuals who are maybe not as familiar with FSP in our county, including our consumers that we work with. So the next slide, I'm just going to go ahead and throw up there, is in Kings County, what has been identified as the FSP criteria for individuals who would be eligible or who may be identified to benefit from our services. So it's anyone of 18 years of age or older who's been diagnosed with a serious mental illness. And then we have different criteria based on our TAY population, our adult population, and then our elder population. So individuals who are 18 to 23 years of age, some of the criteria is, well, it's not some, this is our criteria. They are considered to be unserved or underserved, and one are the following areas. So we talked about being homeless or at risk of being homeless. They're aging out of the child and youth mental health system, maybe aging out of the child welfare systems or the juvenile justice systems, or any involvement with the criminal justice system, at risk of involuntary hospitalization or institutionalization, or they may have experienced a first episode of serious mental illness. So embedded even with our FSP program, we do offer a first episode psychosis program, and we work hand in hand. So it's almost like it's dual enrollment with this wraparound approach to providing services to this particular age group. And then we have our 24 to 59 years of age. So you'll see on the screen, there's the similar criteria regarding homelessness or at risk, involvement with criminal justice system, and frequent utilization of hospital emergency services or inpatient psychiatric hospitalization. And when I turn the next screen, we have the criteria for anyone who then is identified who's age 60 or over. So additional qualifiers would be maybe they were experiencing a reduction in their own ability in their daily functioning, whether it's personal or within the community. There's at risk of out of home care and the need of. So you can see there's some additional criteria for that age group as well. So what our current staffing looks like at this time is we have a clinician, and that clinician also serves in a dual role as the personal service coordinator. So we kind of consider them like the manager. They're the overseer or the team lead, so to speak. So they're the driving force, they're the connector when it comes to the different treatment team, and a guide in terms of what interventions or what may need to be done. And then we have our case managers. And one of the things I talk to our case managers about is they are mighty. And in fact, we have more case managers than we do have clinicians, because they are such a strong component to our FSP team in terms of the work they do with our members. So it's really important that we have a strong case manager presence, and we do. We also have an administrative specialist who's part of our team. I heard in the previous panel presentation, and anyone else who's in the presentation right now who works with FSP, you know that there's a lot of administrative duties, such as the DCR reporting that's collected when working with our clients. And so she is a very huge piece to our team. I let her know that, tell her she's the hub, because she helps us with coordinating and tracking of different things like flex spending, getting that information entered in the DCR in a timely manner, and so much other things. Those are just a few items. And if applicable, we also have a medication services staff that participate, that is made up of both doctors and nurse practitioners, as well as nursing staff and a nursing case manager, and then whom you're going to have an opportunity to hear from in just a few moments. We also have a peer support specialist who is part of our FSP team. I'm so excited about her role and just the work she does. I often refer to her as our member whisperer, because she has such a way to engage clients. Members. I'm a clinician, so I constantly try to reframe my verbiage too. But she just has a unique way in how to engage and connect with them. And I often will have my door open and sometimes can hear just like that human connection, right? It's not all about clinical. It's just like, hey, how's it going? Which I think that social skill component, the ability to connect, is so huge. And she's so caring. I think that a lot of that comes so naturally to her. So you'll hear from her in a few moments. And then, of course, there's a program manager and a clinical supervisor who oversees not only the clinicians, but the case manager. We're part of the team, and we provide that leadership and support for them. We do multiple case staffings per week, just to provide that support and consultation and supervision to help our staff to be able to help the members. So this is a little bit of what our staffing looks like, and I wanted to just provide that. Some of the services we provide. So we try to provide all our services and from a framework of a wellness and recovery based model. So trying to incorporate supportive services that are not only easily accessible, but also culturally competent. We also, at the onset of someone being accepted, well, even referred to the program, we are connecting them with members of the treatment team. And when they're fully enrolled, we definitely assign that team. So that means they'll get an assigned clinician, a case manager, our peer support, they'll be introduced to the team. And again, if medication services are applicable, which most of the time they are, they would also be part of the team and be introduced to the client. Another thing that we try to make them aware of is who their clinician is and their dual role as being that personal services coordinator, as they're that single entity when it comes to just the oversight. And also important, if the member has any type of social support, whether it's family or friends, trying to include them because they're such a huge piece to the members' success. We also work with them in developing a treatment plan that will identify what are their goals, what are things that will make their life worth living. So we have an idea and an understanding of what they would like to achieve. And so really working with our staff to, yes, we have to be mindful of the clinical component, but also look at the other pieces, like the whole person, because that's really going to help us to move forward and align with them to be able to work towards those goals. And so another part of our structure is to try to, at least at minimum or average, have 3 contacts per week. And that could look like a variety of ways. It could be a contact with the peer support, their case manager. It could be a group. It could be meeting with someone on their medication team. And again, based on clinical judgment of what the client needs at the time they're at in the program. So what you're seeing on the screen are just some of the different modalities and how we provide those services. So we have individual and group therapy. I talked about case management. So case management could look different in a variety of ways. So we have our case managers who can help them with skills, making linkages to, if there's like needs, linkages to community partners. It could be even working on different areas, whether it's their educational or vocational or employment or social, any other identified goals. So like I said, case management is a huge part of our program. Like I said, we offered individual and group rehabilitative services, medication services. We do lots of collaboration with community agencies, whether that's with the courts, the probation department, human services, the clients involved with CPS or employment training services, formerly known as CalWorks, public guardian, local shelters, local residential facilities. So I could list on and on, but those are some of the common ones. And then educational services to the consumer. So this could be like psychoeducation to their families and support systems. We do have a comprehensive DBT program at our site. And so part of what we do is we provide a free community class. It's really focused on our members' support systems. And so we provide them with a free skills manual and a 6 months class free to learn DBT skills. And we always preface it as this is not so much to have to teach you how to deal with your loved one. It's more about you also, learning the skills and seeing what they're learning and how you guys can use those skills to work together. And so we open this up not only to family and support systems, but also with community partners. So again, not just treating the member, but also loved ones. So now I'm going to take a little break and I'm going to hand it off to Fallon Martinez, who is going to talk about a little bit more of her certification and some of her tasks that she does.
Hello. I'm Fallon Martinez. I am the peer support here at Kingsview. I'm also a native of Hanford. I've lived all around Kings County. I was born in Hanford though. I got my certification by participating in a 3-week training that provided me with the knowledge of how to support people as a peer support. And then I took a state exam to become certified as a Medi-Cal peer support. And I also continue my education by attending monthly trainings via Zoom to provide updated information how to better support people as a peer support. One of the tasks that I do as a peer support here is I provide orientations to all people referred to the FSP program. In that orientation, I provide a full description of the program and the services and the expectations of engagement from the participants. I also do weekly check-ins, whether that's in person or I contact them over the phone, just to check in and say, hi, how you're doing? And I interact with them and relate to them genuinely to provide support and encourage them to advocate for themselves or maybe their needs. And then I interact with the team by providing updates of how they're doing, maybe current needs expressed, whether their contact information has changed, or maybe discussing barriers that they've mentioned that they're having that prevent them from fully engaging in the FSP program. Thank you.
Thank you, Fallon. So I want to go ahead and conclude with our next slide. So again, I just really want to send my gratitude to be able to participate in this forum. You know, so often when we're working, providing those direct services, it could sometimes, because of the work we do and the passion that we have, it could be draining on certain days. And sometimes it can feel like, gosh, who's making these decisions? And don't they see how, you know, it impacts us? So to be able to have this forum and to even know that this commission exists, I'm so excited and I'm so honored to be able to come, to be able to just share some of the challenges that we have encountered and have seen, and some areas that could be opportunities to be worked on. It was very interesting hearing the previous presentation, as well as some of the comments that were made, because I thought, wow, that's a lot of the stuff that I have on my presentation of some of the challenges that we have come upon. So I just like to, they're all listed here, but I kind of like to go over them and just say a little bit of some of what we have experienced here in Kings County. So one of the hugest ones, and I had to put it on there, was of course the housing resources. We just have a very limited, we're a smaller county in a rural area. And so those housing resources are very few and very thin. And so there's not a lot, and that could be very challenging. Sometimes we have, we've encountered, you know, members saying, you know, I'm here for housing, or you guys aren't trying to help me. And it's not that we're not trying to help, it's just, there's just limitations of what we can provide and what we could assist, because it's just not here. It's not available. And even the shelters, there's like a number of beds, so those could get filled very quickly. And so there's a huge need. Another area is funding resources, is the funding is sometimes not there. And so that could, you know, have its own challenges. We don't have a local psychiatric hospital. We don't even have like a PUF unit. Here in Kings County, we rely on the local hospital that is not really set up for to hold some of our clients who have been placed on a 5150 hold, for example. And so it can be challenging, even in the experience some of our members may experience if they are in a crisis situation where it may require psychiatric hospitalization, and they're in that like holding place where our crisis team is trying to find, you know, a bed within the state. And so there's some challenges with that, not having the appropriate resources at times for our members. A huge one that we've really seen, I think the pandemic has really increased this, is staffing retention. What we've seen specifically on our team, we have a lot of our members, our treatment team is made up of people who have been at our agency for a long time. And so we're looking at the same team who has themselves continued to, you know, provide services through a pandemic, along with other, you know, just the other stuff. So we've seen a high incidence of compassion fatigue and burnout within the staff because of the need. I want to just kind of skip over the next one and tie that into staffing shortages. About a year ago, we lost our FSP team lead to an online platform who provides, you know, services. She's getting paid at a higher wage. She was wonderful, but she had experienced, she had been at the agency for years, and part of it was the burnout. We also lost a licensed clinician in October, and we're still trying to recruit for that position. And it doesn't have to be licensed. We would take an associate level clinician It just really speaks to the staffing shortages that are out there, that there's so much need in positions and it's very competitive. It, you know, back when I was looking for a job as a clinician, it's a very different market now. And so because we're a community-based provider, the competition doesn't make it easier in terms of even when we look at salaries and so forth. So staffing shortages, I mean, even to get enough applicants to be able to interview and to see who would be a fit, it's a challenge. And so I just kind of wanted to tie that in. That's been something we've been experiencing. So as a result, what that means is it leads to more of the task being distributed to the current team. And that's where we can see some of that burnout even being added. I want to go back to the data reporting procedures. So this is another area, I think it was mentioned earlier, that it's important that that data is collected. My recommendation would be, how can we improve that system? It's not a very user-friendly system. I myself had this experience when I was trying to get some IT help. I went through one person and they said, oh, I'm sorry for this, you got to go to this person. So it's very confusing. It makes it difficult and frustrating, especially because a lot of that data has to be entered in a timely manner. So that is also another challenge, to be able to get all that information and put in a timely manner sometimes. Caseload sizes. I could appreciate the state's efforts to try to have this no wrong door approach. However, caseload sizes, I'm not really sure if it was thought out. Again, I'm just speaking from a provider of the infrastructure challenges, that with more doors being open, that means more services for individuals who may have not received services previously. That's a plus, that's a win for us. In terms of staffing, it's a challenge at the same time, because you have this influx of consumers who benefit and meet criteria for these services, just not having the staffing to support it, which then in turns increases burnout, and then also again increases the likelihood that those clinicians will go off to other opportunities. I think training is huge. I'm a huge proponent for training. I think training not only helps your newer staff feel more competent, but it also helps with some of your more experienced staff. Things are constantly changing, and to have like a training one time and think that's going to be it. No, it's that continual changes, best practices, keeping up to date on what's been found to be effective. That needs to continue to happen. And sometimes, going back to funding resources, that means when there's budget cuts, often some of the first step that will go is the budget for trainings. Yet to have a more well-trained staff, I think will help them feel more confident, be more efficient in carrying out the services that they do.
Lisa.
Yes.
I'm going to go ahead and ask you to just, if you could stay with us, but we're going to move on to the next speaker, but I'd like you to stay on for questions afterwards, just so that we can open it up.
Time.
Yes, please.
Yes, absolutely. Okay. Thank you for the opportunity, and I'll go ahead and stop sharing my screen.
Thank you. And please
Absolutely.
stick around so that we can have a discussion afterwards. So with that, I am going to ask Phoebe to go ahead and come on. Melissa, is that correct?
Yep.
Thank you.
Yes. We'll turn it over to Phoebe Bell. Thank you.
Hi, thank you so much. Can you guys hear me okay?
Yes, we can. Thank you.
Great. Okay. Hi, I'm Phoebe Bell. I'm the Behavioral Health Director for Nevada County, as well as the past president of CBHDA. And really appreciate the chance to be with you here today. I'm super sorry not to be there in person. The universe conspired to keep that from happening, but glad to be able to be here, at least virtually. And I am going to share a little bit of information around what FSP services can look like in a rural community particularly, and give some context that way. And I think yeah, there we go. Perfect. So you can jump ahead to the next slide there. So just wanted to start by giving a little context to who Nevada County is, where we sit in the state. We're a relatively small county, and conveniently we're a population of right about 100,000 people. So as I throw out numbers along the way, that sort of helps with extrapolating it to whatever counties you're more familiar with. We have 3 population centers in Nevada County that are referred to as cities, but the biggest one is 17,000 people. So pretty small, Grass Valley, Nevada City, and Truckee. And then we have the bulk of the community living in the unincorporated parts of the county, and honestly living in pretty rural settings. We have a lot of miles of dirt roads in Nevada County, and people living in pretty rural, kind of spread out situations. And then of course we have a mountain pass in the middle of our county, and I'm sure all of you can imagine that this is about what it's looked like for much of this past winter, at many times shut down entirely. You can jump ahead there. Our behavioral health department is small but mighty. We have 3 clinic sites. This is a picture of our adult outpatient clinic. And importantly, you can't see their part of the building, but we are co-located with our full service partnership adult provider, Turning Point, and we'll talk more about that in a minute. We have a staff. We also have a children's clinic where we're co-located with some other children and family serving services, and then a Truckee clinic where we serve both adults and children. And we have a staff of about 58 folks, a budget of 45 million-ish, and we contract out about 70% of our services to really critical partners. Our contractors are kind of closely held in our system, and we work really tightly together to operate as a system of care. So specifically on the full service partnership side of things, we have 3 key partners: Turning Point Community Programs, Victor Community Support Services, and Stanford Sierra Youth and Families. Turning Point serves our adults, and the other 2 providers serve our children's system. We're going to focus more on the adult side today, but all 3 of these providers are long-standing partners of ours. I think we recruited them all to the community back when MHSA first started, and they've been consistent and really strong partners of ours. I also want to acknowledge, though, that Nevada County is really at the big end of small county land, and that many rural counties actually have 0 providers. We're lucky that we're relatively close to, Roseville and Sacramento, and areas where there are more providers and a little bit able to recruit from those areas. And I think the further north you go, the more challenges people have having enough, demand for their services to be able to afford to bring in a full-fledged provider. And so just want to make sure we remember that often counties have to provide their own FSP services because they're unable to bring providers into the mix. Okay, next. So a little bit about what our FSP programs look like. And I know you've gotten a good overview from Kings County, which is great, but so I won't go quite as in depth, but to give it a little bit of a sense of scale, on the adult side, we serve about 75 people at a time in our Turning Point program. We think of it a little bit like slots. That's to keep the low ratios we want to keep of staff to clients. That's about how many people we can fit into our FSP program. Commissioner Rolette, I don't know that you would agree, but I think you would. We refer to Turning Point as really very close to Fidelity ACT services, but a little bit more flexible than full Fidelity. It's a really comprehensive array of services, and similar to ACT, it's a lot of the 24/7, whatever it takes, meet people where they're at. Big focus on personal service coordinators and care coordination and management in that way, and just a really, really quality service. I think what's important to note, though, that we really have come to recognize as some of the biggest strengths of our adult FSP program are 2 aspects of the services that they provide that we have found to be critical in helping keep people stable for the long haul and really limiting the number of people that we need to place in the long-term inpatient care. We have really low rates of people in IMDs and MHRSs, and I think it's a lot because we have these two great services. So one of those is medication delivery. So pretty much every day of the week, or literally every day of the week, Turning Point has staff who go out to people's homes and deliver medications to them, watch them take their medications, check on them, make sure they're eating and safe and doing okay, and alerting the team if there's a problem. And it's an incredible intensity of service that allows people to stay well in the community setting, and really has been a game changer for a lot of folks. Turning Point also has a lot of housing resources that they manage. Some of those are houses that they own or master lease through MHSA funding that we've been able to bring to the table. Some of those are housing resources that the county has, or that are other providers. We have a housing specific provider, maybe they own it, but Turning Point manages it. At any rate, about half the folks in their system have access to housing that we're able to provide collectively. And as we know, that's a really critical element of stability and well-being. On the youth side, we're able to serve 80 kids at a time at Victor Community Services. We tend to have a shorter length of stay in our children's wraparound programs, more like 10 months-ish. So over the course of a year, we tend to serve more people. But it's the similar full, wrap around, be there whenever parents need you, families need you, young people need you, and wherever that may be. We really find our parent partners and peer supporters, both in Turning Point and in our youth serving programs, are really critical. And then Stanford Sierra is our smallest and newest FSP program, but also a critical partner, doing great work kind of with other services that are a step down from FSP. Next slide there. So what makes FSP a little bit different in a rural community? Just wanted to highlight that piece. I think you got a good sense yesterday probably of really amazing urban-centered FSP programs. And in many ways, we're not that different. But I think one of the things that's hard to kind of overemphasize of what's different in a smaller community is the way in which care can be pretty personalized. Because our numbers are relatively low, we tend to know our clients pretty well across our system. And we tend to be able to really understand collectively between Turning Point and ourselves, or between our children's providers and ourselves. Most often our highest need folks bounce between our systems as appropriate and as needed, and we all get to know them. And we very well might bump into those same clients in the course of our daily living and in our community settings. And it creates a much more a web of support that's a little bit more seamless across levels of care. I think, at least it feels that way, just because it's more personalized. And I think also being co-located with our programs, we're able to really have fluid movement back and forth between levels of care, and we can operate not just our kind of treatment services, but also our housing resources and our crisis services, like our peer respite center that Turning Point runs, or our CSU, or our adult residential facility, or some of our many housing resources. We can collectively look together and say, so-and-so's coming out of the hospital. We need a bed at respite. Can we bounce somebody over to that new slot at the housing at Orchard House that just opened up, and that type of thing. And I think that gets to that last bullet, where flexibility has been pretty critical. The ways that we aren't strictly to fidelity, I think, has been because we really strive for that flexibility to be able to really meet people where they're at with the needs they have, and bring the highest level of care that's needed to keep somebody safe and stable in a community setting, and well supported. Next slide. So what are we seeing? What's the impact of these really amazing programs? We see incredible outcomes, and they're very aligned with what the ACT research has found over the years as well. For the 21-22 year, of the 80 individuals that Turning Point was able to serve in Nevada County, 89% stayed housed, 86% avoided psychiatric hospitalizations, 93% avoided arrests or incarcerations, and 18% gained or maintained employment. And I think, as you're aware, we identify people for our FSP level of care who are having a hard time in many of these areas, and typically have a pretty tough history of hospitalizations, arrests, homelessness, et cetera. And so to get to these kind of outcomes is really exciting and inspiring, and I think really speaks to the effectiveness of this flexible, adaptive, supportive, holistic type programming. And to just also say, all of our providers, and staying on the adult side, Turning Point in particular, just come at this work with a deep belief in the inherent worth and value of every human being that they are privileged to serve, and really believe deeply in recovery, in people defining their own path to recovery and what that looks like for them. And it's just a strong program, strong system. Moving ahead to the children's side in terms of outcomes. Thank you. We served 131 youth between our two programs, so a little bit higher rate of turnover of slots as intended, but similar really incredible outcomes in terms of stability and well-being. Also, we get to see in this front the ways that being supported like this leads to better success in school, which is so important, and also well-being for caregivers and family members. Feelings of connectedness in the community and skills to parent their young people, really increasing and improving, which is exciting. So moving on to, those are the great outcomes. What are our challenges in implementing FSP? Don't mind jumping ahead there. Sorry, I keep clicking myself. So as you've heard already from others, but I can't underscore it enough, probably the biggest challenge we face is around housing. This picture here is a project that opened this past year. That's a No Place Like Home and tax credit and Rural Housing Authority partnership program. We added 40 units of housing for people leaving homelessness, 12 of which are dedicated to people with serious mental illness in permanent supportive housing. Super exciting. We have gone after every grant one could go after over the past year or two. There's been great opportunities to add resources in housing. And as for a small county, I think we've been remarkably effective. I think over the past year, we added 72 beds of housing, specifically for people leaving homelessness, most of those for people with serious mental illness or substance use disorder needs. And we're really proud of that work in those 72 beds. And in that same year, 200 people became homeless for the first time in Nevada County, so it remains incredibly stressful trying to house our clients. I will add that one of the housing units that we added during that past year was with MHSA dollars. We took about $900,000 and purchased a house that Turning Point's operating for us. But I want to flag that that's really actually hard to do under some of the current definitions that exist, because that housing, even though it's going to serve FSP clients, doesn't count as an FSP expenditure. We have to continue to balance that 51% of our CSS funding on FSP with our ability to spend on the other side of our CSS bucket. And so when we spend $900,000 on a house, we have to balance that with FSP spending. So when we have, especially when we have one-time funding, it can be really challenging. One-time increases in funding, it can be really challenging to use it for the purpose we know we need, which is more housing. So just want to acknowledge that challenge there. Jumping ahead, another big challenge is workforce crisis. And again, you've heard a fair bit about that, but want to continue to reiterate that. Us and many of our providers are running 20 to 30% vacancy rates in particularly clinical positions, but really across the board at times. Vacancies are staying open for long stretches, which really impacts capacity. And often when we're hiring people with a lot less experience than we ideally would like to be hiring at this point. And I think that's important to flag, just given the challenges of this work and the complexity of this work. And so when we have a more green workforce doing some of the hardest work in our system of care, that creates a lot of stress in the system. Also, just to flag, because we'll turn to dollars in a second, that the vacancy rate issue also impacts our ability to spend MHSA dollars at the rates we plan to spend it at, because so many providers are kind of coming in under budget as they're unable to fill positions and generate units of service, essentially. Next up, this is, I was smiling to myself when some of the earlier conversation was happening around meaning and purpose, because we couldn't agree more. And we know that our providers couldn't agree more either. And we increasingly have been focused on, it's not just enough to help people have the tools they need to stay stable, whether that's housing or other resources, but instead, how do we help nurture people's ability to find their sense of purpose and their connection to a meaningful life? We are in the process of adding IPS, evidence-based employment program, but we've also been really trying to add more and more sort of activities and groups that nurture social connections. This is a picture of one of our youth groups that's a mountain biking group. And, you know, a couple of therapists and a group of young people taking time together in the woods, getting to know each other and facing challenging situations and working through whatever their issues and roadblocks may be, and building and nurturing connection and activity. Those types of things we're trying to do more and more of across our system, and particularly with our key FSP partners. So jumping ahead to the fiscal picture of running FSP programs, I know this zigzaggy chart is not necessarily new to any of you, but I just want to really underscore the challenges of managing MHSA dollars from the county behavioral health director perspective. It's worth saying them out loud because it's pretty amazing. We have no other revenue stream that looks like this. Down 14%, up 64%, flat, down 40%, up 160%, down 34%. Those are pretty wild fluctuations. And I guess just to put that into real dollars in Nevada County, for this current year, we projected to take in about $7.8 million. So a year ago right now, that's what we thought our revenue would be for 22-23. And we plan to spend about 7.3 of that. So pretty much bring in and spend what we, you know, on a par with each other. We're now projecting 4.4 million in revenue, which would be horrifying, except for the fact that we are able to do that, to absorb that decline in revenue without making any cuts in our programs, because we have a little bit of lag time between the revenue coming in and our spending out the door. And so we feel really relieved and proud of our ability to not make a cut in a year like this, and to really try to manage for that through line across the sort of midpoint of these wild fluctuations up and down. And if we go to the next chart, you can see a little bit more what I mean there. It's always a little anxiety provoking to share our detailed financial information, but I felt like it was important to do, to just show you how counties are trying to tackle these ups and downs. So again, remember this year, we're going to probably end at about 4.4 million in revenue overall. Next year, big increase, super exciting. Following year, back down a little bit. And so we're settling on a 3-year plan level of expenditure that's pretty aggressive, because traditionally what happens is our expenses are coming in a little bit under due to that workforce crisis I was talking about. And oftentimes revenues seem to exceed projections, and we're left holding more resources than we want to hold. And we don't want to. We want to spend, and we want to get services out to people. And so we're going at this pretty aggressively, as I think most counties are, to try to find that midpoint again, to balance those highs and those lows, and to spend responsibly in our communities by the services that we need, but not start and stop programs unnecessarily. Jumping ahead. On the next slide there. So other issues as we look ahead that I just wanted to touch on, topics that we're paying attention to, multiple state reform initiatives, and I'll dive into a couple of those real quickly in a sec, but also wanted to flag the impacts of payment reform. We are in the midst of a pretty significant change in the public behavioral health system and how we are paid for the work that we do. It's changes at a lot of different levels all at the same time: the units of service, the way the money flows, the shift in risk essentially from the state to the county. And it's a big learning process for us. And we are working hard to understand how to make the most of this opportunity, how to support our providers in the best way we can through this transition. And it's a hopeful time, and we all remain optimistic that the future should and could be bright, but it's an anxiety provoking time because we're not actually sure about that. And it's all about, do the rates work? Are we going to produce units collectively at the level we need to generate the revenues we need? And so it is a very challenging time to plan ahead in the behavioral health system. And I think a year from now, we'll all have a better sense of what that payment reform shift is looking like and what opportunities or challenges it's created for us. And then lastly, that ongoing growing demand for FSP services. Sorry, back on that last slide for one more bullet. We coming out of COVID, and I think I forgot to stress this back on the slide about meaningfulness and connectedness. We know that the demand has never been higher, and this is without adding new populations. We know that the acuity of our clients continues to rise. And I want to add that in rural communities, the isolation that often is experienced based on typically almost zero public transportation, big geographic area that people are spread out around, and lack of sort of population centers to easily come to, having connectedness through services and supports can be really critical for the folks we serve. And so that demand for FSP just continues to grow. Okay, jumping ahead now. So the two state reforms I just wanted to touch on. We know that you'll be hearing more today about the governor's proposal, and we certainly are paying close attention as behavioral health directors as well, trying to understand how some of these changes will impact us. In Nevada County, we're worried about the essentially decline in the FSP bucket. We spend closer to 55% of our CSS funds on our FSP programs right now, and so we wouldn't want to need to cut back our FSP services. I think the opportunity to invest in housing and housing services is exciting and critical and needed. And I worry across the board about sort of the concept of prioritization, essentially as a euphemism for some things we need more of, which means some things we need less of. And how do we decide what we need less of? Because we kind of need it all, is how I see it. And I'll add to that similarly around adding in the substance use disorder population, couldn't be more needed. 100% support adding the type of funding that we have on the mental illness side right now to the substance use side. And I am anxious about doing that with the same pot of money and spreading it across more people with significant needs. So those are the things we're looking at and trying to pay attention to and figure out how to make this work as well as possible to meet the needs that we know are intense and out there, and we are desperately trying to address and serve. And then lastly, the other proposal that we're tracking on closely as well is the DHCS behavioral health waiver proposal, which is also exciting and hopeful and a lot of promise as well. And we're trying to figure out how does the work we're doing now with FSP, that's such a critical part of our system, fit with doing Fidelity Act and our experiences as a state with some of the challenges around High Fidelity Act and the flexibilities of FSP, and yet the opportunity to generate more Medi-Cal revenue for this important work. And all the other aspects of the waiver are exciting and also going to take some work to make sure that it's all for the positive. So with that, I am happy to answer any questions and appreciate your being willing to hear about all of this.
Thank you so much, Phoebe. We have one last presenter, Nicole Christie, who is with Third Sector and has been working on the multi-county full service partnership innovation project. And so Nicole, I'm going to turn it over to you and just ask, I know we're a little behind schedule, so we will have your full slide deck, but if you can focus on kind of the high level takeaways from the multi-county collaborative project, that would be great. Thanks,
Nicole. Hi, everyone. Yes, Melissa, understood. I think Jess, my colleague Jessica, is here with me, and I think she can share the deck to maybe even help expedite things along. So Jess, if you want to share your screen while I just quickly introduce us. Hello, everyone. I'm Nicole Christie. I'm here with Third Sector, and I am going to present on the Multi-County Full Service Partnership Innovation Project, which is a collaboration of 9 counties working together to improve FSP services and outcomes. Real quick, who is Third Sector and why am I here presenting on this? Well, we're a national nonprofit technical assistance organization, and we have supported this project and continue to support the project over the past 3 years. So My objectives today were to give you a quick overview of the project and then discuss some of the similarities and differences in FSP programs across our participating counties, and also share some key takeaways from the project and thoughts on how we can continue capacity building through technical assistance to improve FSP programs. Noting the time, I'm going to go through this a lot quicker than I had anticipated, so bear with me. But I'm always happy to answer questions after the fact. So real quick, how did this get started? So, FSPs, we've talked a lot about how they take a whatever it takes approach. And because FSPs need to be tailored to the individual, counties are provided a lot of flexibility in how to operate, which really support community responsive services, but that flexibility can sometimes create inconsistent processes and data, which can make it challenging to understand the overall impact of FSPs, especially across the state. And so the Multi-County FSP Innovation Project grew out of that challenge. We first did some work in LA County to transform their FSP contracts to really focus more on member outcomes and incentivize serving those who are hardest to reach. And then in 2020, we had 6 original counties, Fresno, Sacramento, San Mateo, San Bernardino, Siskiyou, and Ventura, in partnership with the MHSOAC, Cal Mesa, RAND, and Third Sector, launch this innovation project to build off some of LA's work. In the fall of 2021, 2 additional counties joined, Lake and Stanislaus, and Napa, our 9th county, joined in the summer of last year. Next slide. I will not read the project goals to you, but at the end of the day, this project's really trying to help counties improve their ability to collect and use FSP data in a meaningful way to really understand who is being served, how they are being served, and if they are better off as a result of those services. Next slide. So here's the timeline, the general timeline. It's a 4.5-year project. And essentially in 2019, we started planning for this innovation project. In 2020, the project officially launched with those original 6 counties. And the project's divided into 4 phases. So we have a landscape assessment phase where we really gather context within and across the FSP programs we're working with to explore similarities and differences. We then move into design and implementation to design solution to some of those challenges that are identified and create more consistency and some improvements within a local context. We have a sustainability phase that ensures counties can sustain this collaborative and continuous improvement processes that incorporate stakeholder voices, especially providers and members. And then finally, there's an evaluation phase. And so right now, the original 6 counties are in that evaluation period. RAND is the evaluator, and they're doing both quantitative and qualitative analysis on the project. The counties that started a little bit later are on this same structure, but a little bit of a different timeline. So I'm going to go real briefly over each of these phases to give you all an understanding of what the project is focusing on. During the landscape assessment, I mentioned we're really trying to explore similarities and differences across FSP programs, and we did that through really extensive engagement with county leadership, staff, providers, and members. That was really a core value of this project, and you can see some of the numbers of folks we engaged on this slide. We really examine the full spectrum of an FSP program, from enrollment and eligibility criteria to graduation processes. And we saw a lot of variation in programs, both across providers within the same county and also across counties. We also saw a lot of common challenges. So for example, most counties didn't have a consistent graduation guidelines or measurable metrics on how or when to step a member down to a lower level of service, making it difficult to make some of those graduation determinations. Data collection and reporting practices also varied significantly across counties, but all counties shared some kind of challenge around getting the data that they needed in a timely manner to really understand the results of their program. Now, this is not to say that all variation is bad. It is not, taking a whatever it takes approach often means needing to cater programs to the needs of individual members. And the counties in this project were very different. We went from rural and frontier counties like Siskiyou and Lake to much larger counties like Sacramento and Ventura. And these differences meant that programs needed to have slight variations. I think just like Phoebe was mentioning, especially in rural counties, you know, it really does matter the context of the population in the county. There were some things, however, that the counties agreed should be made consistent, and that's what you see on this slide. So based on all of the information that we gathered during the landscape assessment, we came back together and we started the design and implementation phase. And this phase was divided into two groups of activities. One was all the participating counties worked on a set of things together as a cohort, and then each individual county also worked on activities to address things within their local context. So what you're looking at here is at the cohort level, all counties worked together to really try to standardize population definitions, outcome and process metrics, and also make recommendations to improve data collection and reporting across the state. So I won't dive into these details just for lack of time, but I do want to mention some of the outcomes that the counties decided to measure in a consistent way were increased stable housing, reduced justice involvement, reduced utilization of psychiatric facilities. Those all probably sound familiar, but they also added increased social connectedness. And that last measure is especially exciting addition because it was elevated directly by FSP members as an indicator of their own wellness and recovery. Next slide, please. I mentioned the other part of the design and implementation phase was counties working within their own local context. And so each county picked 2 or 3 local initiatives to improve their county-specific FSP programs. You can see on this slide, it was a wider range of things counties decided to work on. Step down in graduation guidelines was a very popular one. I think as process redesign on that was really heavily based on member and provider input. So, you know, as a consistent TA provider, third sector was actually able to elevate a lot of best practices across counties. And so while not all of the final outputs of that activity were exactly the same across each of these counties that worked on it, there were foundational principles, and we were able to really effectively and efficiently share tools and processes and ideas across the cohort so that, you know, the cohort could benefit even if there were nuanced results. Next slide, please. And then finally, I mentioned there was a sustainability phase, which was really meant to just ensure the long-term success of the efforts. And then RAND, at the end of third sector's technical assistance, begins the 2.5-year evaluation. So I will just end on a couple of lessons learned from this cohort so far. We really came away from the project with a strong feeling that the cohort model offered a lot of great opportunities for cross-county work, while also balancing the need for individualized support based on local county context. So there's so much value in doing cross-county work, especially when there's shared vision and goals. And at the same time, each county has unique needs, and it's important to recognize those and identify when standardization is appropriate and when it may not be appropriate and local nuance is really needed. I also just want to highlight that the cohort approach created a lot of additional space for informal connections that have been really valuable, and I've watched the counties continue to connect in an ongoing way. You know, one county has a specific challenge and then they bring it to the group, and the group is able to discuss, you know, what's going on in different counties and share information in a really meaningful way. And then finally, what do we see in the future here? Last slide. So, you know, we did a lot of great work on this project. We started back in 2020, but there is, of course, still more to do. And as we think about a statewide vision for FSPs, we see a lot of opportunity to continue to expand community engagement, to involve community voice and decision-making, increase the amount of knowledge and best practices that are shared across the state, not only within these 9 counties, and to really grow capacity that is so desperately needed, as we just heard from Kings and Nevada, through coordinated technical assistance. I won't go into too much detail here for time, but I do want to just name, we are having another statewide learning community on May 25th, and the registration for that event will be going out in another week. So with that, thank you so much for having me. On the next slide is my contact information, and more information is available on Third Sector's website. I'm sorry that I had to speed through that so quickly, but we will stick around for questions, and you can always reach out to me directly.
Thank you so much, Nicole. So that concludes the panel presentation. So I think we can move to commissioner questions.
Thank you. Thank you, Melissa. I see Commissioner Carnavale, please.
Thank you, Chair. A comment question for Third Sector and then also for Nevada County. Regarding Third Sector, first of all, thank you for adding the increased connectedness. That seems like a movement in the right direction. I was going to ask Dr. Pilon, you're encouraging those outcome measurements, but I didn't hear specific measurements. I'm wondering if you have specific measurements you might recommend that this group consider to expand even more aggressively in that direction.
So I was really excited to hear that too, Commissioner, and I'd like to join that biking group. It sounded really, it sounded really good, actually. And in the Third Sector presentation, there was also the report about looking at social or self-reports of social connectedness. So there's a commonality between those two things. And when it comes to that, I think that self-report of are we actually creating those kinds of social connections is a fine way to go. There's not a problem with that. It's like if it's obviously the members are realizing that increases their overall health, and that's a good way to measure that, I would say. Yeah.
But what about outcomes around, you'd mentioned education and employment? How do we?
Are they going back to school, or are they getting jobs?
Are those literally the two measurements?
Absolutely.
Yeah. So I would encourage the group to think about expanding in those directions, because those are literally the outcomes we're trying to get to. So let's measure them rather than pieces that build toward that alone. Moving to Nevada County, to Phoebe, I guess, this is such first of all, again, congratulations on running such a great set of programs. But we're listening to the challenges, and it's trying to unbundle them and then decide, okay, what do you attack to help solve some of these challenges is a little bit confounding to me. It seems like one of them is around money and funding and so forth. I guess I wanted to ask Phoebe first, is the problem that you don't have enough money, or is it the flexibility around the money? And I heard from Dr. Pilon this idea that coupled from Medicare and being able to spend without categorization, if I understand that, would have been more successful. And I hear it sounds like there's some innovations coming that might start to do that. But which one is it about, or both, or is it something else that I don't understand?
I think I would say from my experience I don't want to pretend to be an expert in every county's experience with MHSA, but it's both, and. In Nevada County, if we had more money, we would serve more people, provide more housing, provide more comprehensive services, all of it. And it's the flexibility to be able to more nimbly move between our sort of current existing buckets to be able to meet the needs of the day. I don't think when the buckets were created 10, 15 years ago, we foresaw the housing crisis that we have today. And so being able to flexibly address that need when we have unexpected revenues, one-time revenues, and want to spend them quickly to meet an urgent need that the people we serve have. So it's being able to do both, have the pot be bigger and have the flexibility between sort of buckets be more fluid so that we can adapt as needed.
So help me understand, you're indicating a lot of variability and not enough money funding, but when I look at our own website and I look at Nevada County, I see that there's $110 million of unspent money, and that's going to grow substantially, it looks like, over the next year. And if there's a shortage of housing, why is the county not taking some of that money and spending on housing? That doesn't have to go to the existing budget. I don't understand why the budget is so limited, and we sit here trying to figure out how we're going to explain to taxpayers who've paid money into the system to solve mental health crises, and the money is, there are billions of dollars being left in the system unspent. Can you help us understand that better from a county viewpoint? What are we missing here?
So first off, I'm pretty certain we don't have $110 million, but if we do, I missed it and I want to find it. I think the things to recognize, and I hope that zigzaggy revenue chart helped highlight this. It's really hard to spend the money in the year it comes in because you don't actually know what it's going to be, and it most often misses whatever it was projected to be pretty substantially. And so we're setting our spending goals based on projections that are unstable and that are volatile. And so again, like in Nevada County, we've set our next 3-year spending goal at about $7 million, which is less than we'll take in next year, but 3 million more than we took in this year. And that feels like a pretty fair place to aim for. So first off, there's that, like managing a very volatile funding stream in a responsible way. And again, so that we could get through a year like this with 40% less revenue than we planned on having and not cut a single program in a time when we couldn't need programs more than we currently need. So the revenue fluctuations don't relate to the demand fluctuation. So that's a challenge. But secondly, it is that it's the rigidity of the current pots in which we have to spend money. So again, after you take off innovation, 80% goes to CSS, 50% of CSS has to go to FSP, which means you have 50% for general systems work. That's where your housing purchases can happen out of. But if you have, I don't know, $4 million of CSS and you're spending $2 million on FSP, but suddenly you have $5 million this year because you got more revenue than you thought, you can't boost your general services spending to purchase a house because now your ratios are off and you're not hitting your 51% on your FSP side. And, I can't call Commissioner Rolette up in the middle of February and say, can you increase your program by $500,000 this year so I can buy a house on my other side of my bucket? It does, programs aren't nimble in that kind of way. And so you get stuck in ways that you don't plan to get stuck. Does that make any sense? Sorry, it's a little in the weeds.
Yeah, well, it makes sense, and I understand that challenge. And it looks like maybe I've gotten the wrong figure. It's not 110. That includes several counties, so the number's probably smaller. But there's definitely unspent funds there. And if it were 10 years ago, I'd understand the argument that you don't know what's going to happen over the next year. But the money has only gotten bigger and bigger and bigger and bigger, and there's close to $3 billion now in the system. It looks like it's going to grow to over $5 billion. And in Nevada County, I'm sure it's significant. So I would just encourage you to look at that number again, and maybe all counties need to be more aggressive in thinking about spending that money, because it looks like it's not going smaller; it's only getting bigger. So something I would encourage you to look at. Thank you.
And I hear you, and I think every behavioral health director is right there with you in like the need is urgent and the need is now, and people are suffering. There's no question about that. But I'd encourage you also to look a little bit globally. Like when we look at reversion, counties are given 3 years to spend MHSA dollars because, again, it's so volatile and it's so hard to predict, in the same ways that the state struggles with spending unexpected revenues in the same year it comes in. And when we look at reversion, less than 1% of all MHSA dollars revert. Counties get the money out the door in their legally required timeframes. But specifically in Nevada County, we've worked with our community to set sort of a buffer that we all feel is important. So we typically have about 50 to 60% of a year of expenditures in our unspent funds, so that, again, when we have a year like this that ends up down 40%, we continue onward. We have the money, we'll overspend. And as you could see from our 3-year plan, we're planning to aggressively spend moving forward, because some of those projections continue to not hit the mark, particularly around expenditures in a workforce crisis. And so I think that I would argue directors are doing their utmost to spend this money effectively and efficiently, and we are. And I think you heard today about the impact that those expenditures are having on really important and incredible programming.
And Phoebe, I stand corrected. I got the corrected numbers and it turns out Nevada County actually is one of the best counties at spending your money. So I've beaten you up for the wrong reasons, but I'll take advantage of you as an example of many other counties are not spending their dollars. And so the argument is the same. It's just not to you. So thank you for the hard work that you guys do.
Thank you.
Hi, Phoebe. This is Al Roulette, today Commissioner Roulette. You referenced in your presentation that 80% of your services approximately, and was actually 79 that you had on your slide, was contracted. And I believe that that necessitates a particular type of approach where contractors or non-government organizations like Turning Point, and I again acknowledge that Turning Point has been a longstanding partner in Nevada County. But from our perspective, the approach that you take works, and that it's a partnership that one of the most important features of which is a degree of transparency that I think at times makes us both uncomfortable. Could you talk about that? And I think that it's necessary, by the way, and I say that for everybody on the commission, that because such a vast percentage of the services in California are contracted, that this notion about transparency that's achieved in Nevada County makes the working with Phoebe, as I've said to her, even when we disagree, it's a disagreement that's predicated on facts and transparency. Could you talk about why the department has taken that approach? And again, I want to applaud you. I think it's very successful.
Sure, thank you. And yeah, that's obviously a two-way street. I think from where I sit, we need our providers more than you need our funding, really, because money without people doing amazing work is just money, and it's not going to help address the needs that we all have out there. And also from where we sit, the more sort of doorways into support that exist, whether it's, the literal Turning Point doorway or Victor Community Services doorway or whatever, versus just the county building doorway, the more access and options we have to give community members that are more comfortable for them. Lots of people don't want to walk in county buildings. Lots of people want to find somebody that is more comfortable, has shared experiences with them, looks like them, has lived experience like theirs to connect with first and foremost. And so anyway, I guess like starting from that place of like, it's a mutual dependent system. We have to work together. We all need the knowledge of what the big picture looks like so that we can trust that we're all making the best decisions we can for our communities and the people we serve. And that only happens when we're able to like share information honestly and partner in making the hard decisions and at least hear each other's input on those hard decisions. And I think, I really want to stress, I have gotten to know all the behavioral health directors over the last handful of years I've been doing this job, and there's nobody out there with bad intentions. Everybody wants to do the right thing for their communities with their partners. And it is really hard and complicated work. And we are only as strong as sort of all of us together can possibly be. The collaboration is critical to the system well-being.
Well, again, I would endorse, Phoebe, that you continue to advance all the proponents of transparency, specifically as it relates to the relationship between yourself, especially in this new era under CalAIM and payment reform, that you advance now very successfully, because ultimately, again, in conclusion, it's the end user, the consumer, and in Nevada County, you get to see them because it's a small community of 100,000 people. And so it makes a difference how we engage the funding entity or the county, and in Nevada County, it is an experience that works. And so I wanted to emphasize that for all the commissioners today.
Thank you. Just a couple of things. I wanted to acknowledge what Lisa had talked about regarding the workforce shortage. And when you have agencies, they're losing staff to agencies that are providing, Lisa, if this is correct, and I don't know if you're still on there, but providing telehealth services. Was that correct that you mentioned that you're losing staff?
Yes, to the private sector, going into private practice and working for online providers.
Yes, and I think, and you know, there's this discussion because we're seeing more and more of the telehealth services that are being provided and being offered even in our school communities. And so I think that, you know, it's something to think about, that that's another, you know, it's really weighing on the system. So thank you for lifting that up. And to Phoebe, I'm looking at the slide and your statistics, you're knocking it out of the ballpark. And I'm wondering, for those that you served, was there a waiting list for those that are not being served? I'm just wondering, like, you know, you were serving the 80 individuals and then 131 youth. And I love that you included the academic performance. You know, it goes back to exactly that, right? Staying engaged in schools, and for adults, the employment. So are you meeting the needs of your community? And I also noted that you said, you know, just if I'm right, the 200 more people or 200 people for the first time this year in your community are homeless. Is that correct? Is that what I heard you say?
Yes, exactly. In our last point in time count, we identified 200 people who became homeless for the first time during that year. And then in terms of your question about sort of wait lists, it's not like that. There's nobody waiting for FSP level care that's not getting services. It's just we're supporting them with our normal outpatient clinic staff, our own case managers and therapists and psychiatrists, et cetera. But do we have more people who would benefit from a more intensive level of service like our FSPs are able to provide? Definitely.
Well, I want to congratulate you. I mean, these are just very impressive what you're doing there, and, you know, for all the work that you're doing, it just really congratulate you. And Nevada County is, you know, benefiting from the great work and the partnerships there. So thank you. And thank you for being here. I want to thank everybody. Lisa, Fallon, Phoebe, thank you for being here. And of course, Dave and Michael and Nicole. Did not forget about you, Nicole. So thank you all for being here and taking the time to inform us. And we will continue to look into this and see what we can do and how to, I'm sorry. Oh, no, thank you. So we are going to move forward, and tell me if I'm missing something. Yes, we are going to ask now for public comment. If there are no other questions or comments from our fellow commissioners, we're going to ask for public comment. So Amariani, if you would like to please, at this time, members of the public may request to make a public comment on agenda item 6 by clicking the raise hand button on your computer or the app, or if calling in by phone, pushing *9. Once the public comment period for this agenda item starts, we will close the public comment queue, so please make your request to comment now. Are there any public comments? Please raise your hand now as the queue will be closing. And I will ask that you please limit your comments to 3 minutes or less. Amariani, please open the line for public comment on agenda item 6, and let's start with comments from within the room.
Okay. We have one comment in the room. We have Stacy. You can go ahead.
Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. Great presentation. I especially like the presentation. I'm because I was with MHAC. So thank you, Michael, for your story too. In the interest of time, I'm going to make it really short. I really suggest you look at the recommendations that Dave Blon gave you, because I think they really hold true for not only this is what I was delighted, huge, because I visited the village several times. It's a huge program. It's a huge place, but these recommendations, and especially your comments about how going toward Medi-Cal really changed the nature of your program, and it was very difficult, holds true for so many of my racial ethnic organizations that serve those particular communities. Everybody wants to push them to Medi-Cal, you know, to get that dollar. Yes, we don't want to leave dollars on the table, but they said, Stacey, this is changing the nature of our, exactly what you said. It's changing the nature of the program. One of the best programs they have, I won't say which, they almost went under because they their workers, everybody hated what they were doing compared to before when they weren't trying to get Medi-Cal. And with the governor's proposal to try to push more Medi-Cal, again, of course, it's all because we want to save money. But if it's going to change the nature of the program to where it is just, again, the MHSA was to transform the mental health system. If we're just going to go back, it's the wrong direction. So thank you.
Thank you, Stacy.
Online, we have 3 public comments. First, we have Dewan. Your line is open.
Thank you. I'm not sure if you can hear me okay?
We can hear you.
Oh, perfect. Okay. Thank you, commissioners. I had in my notes, good morning, but it's good afternoon at this point. Dewan Utek, I am the director, the Chief Development Officer for Telecare Corporation, previously the Director of Behavioral Health for the great county of Fresno. Happy to hear them get some funding this morning. Thank you for your focus on FSP, such an integral part of the behavioral health continuum of care. Telecare is a person-centered, recovery-focused statewide provider operating since 1965, offering services in 23 California counties and in Washington, Oregon, and Nebraska. Over 50 of our 135 programs offer full service partnership or assertive community treatment levels of care. We are one of the largest providers of FSP and ACT services in California, serving over 15% of the FSP served population in fiscal year 2021, which was referenced in the Commission's report. Our full service partnership and ACT serve over 9,000 individuals annually, including transitional age youth, adults, and older adult populations. We have specialized teams for justice involved persons, including those under a Department of State hospital or misdemeanor diversion, and persons experiencing homelessness. Our systematic approach to care strives to empower those with the most complex needs, no matter the setting. We participated in the state's first pay for performance program for FSPs in Santa Clara, Partners in Wellness, which just ended the last year largely because it was successful and enabled Santa Clara to greatly grow their FSP programming. Our programs do adhere to FSP and ACTs to deliver intensive outreach to maximize engagement in partnership with those served. The people we serve have the most success in supporting their recovery when there are complementary pre and post services, robust and complementary transitional and permanent supportive housing options, and the psychosocial supports that were previously mentioned. A robust continuum in a community ensures that clients progress through the levels of care to support right care, right time, right setting. When this happens, we see upwards of 60% of individuals having stable housing and or transferring out of an FSP to a less restrictive or less intense level of services. One recommendation is to move away from a fail-first system of FSP referrals. Currently, to qualify for a referral, folks must have repeat hospitalizations, incarcerations, or crisis visits, as you heard earlier. While the need for an FSP is clear for these individuals, less rigid criteria could increase access to services earlier in their course of care. Another challenge in the policy and practice arena is the need for a statewide credentialing system. Delays in credentialing can limit the ability of providers to quickly deploy scarce staff and increase access to care. Another challenge is the manual and at times arbitrary nature of data collection, developing the standardized data sets that were recommended across the system, not just for MHSA, which could be built into electronic health records and then uploaded or transferred through an information exchange would improve data collection, data validity, and help drive a more data-driven system of care. Further, the elimination of superfluous data collection increases the available time for scarce staff to focus on person-centered, recovery-focused care. To build capacity, it would be helpful to understand if there are certain approaches or modalities that would better benefit. Thank you.
Thank you.
Next, we have Patricia Moreno. Your line is open.
Hi, thank you. Good morning, Commission Chair and members. My name is Patricia Moreno Gonzalez, and I'm here on behalf of the California Council of Community Behavioral Health Agencies. CBHA is a statewide association of nonprofit agencies dedicated to providing mental health and substance use disorder programs and services to those in need across our state. Some of the members that we represent are full service partnerships and are also sitting on today's panel. We strongly believe that full service partnerships foster the much needed capacity to serve adults with severe persistent mental illness. We're in full support of the comments that were made by Commissioner Rolette and discussing the importance of FSPs and the work that they do for different communities. Thank you so much.
Thank you, Patricia.
And our last public comment, we have Laurel. Your line is open.
Just trying to get my video on. Why not? Why is it? There we go. Okay. All right. So this is Laurel Ben-Hamida. I realized I forgot to introduce myself earlier when I was commending the commission on the information notice about PEI priorities. I am with Muslim American Society Social Services Foundation in Sacramento and with REMCO. I first want to say, yes, thank you. MHA has done so much in the past. It was Richard who gave me the first opportunity suggesting that I apply for the CLCC committee. When I was just getting started, Stacy was mentoring us. And Rusty Felix was encouraging us to be at the table. I especially appreciated and will recommend the first panel, not because the second panel wasn't good, but the first panel gives the background that a lot of young advocates or new advocates need to know as they learn about the MHSA and what's been done by the people who laid the foundation for the work that's being done now. And of course, the information about today, some of it we know because we run into workforce issues too, and so on great needs. So thank you very much. Worthwhile panels.
Thank you, Laurel.
That was our last public comment.
Thank you, Mariani. All right, at this time, we will now break for lunch. We will take 30 minutes for lunch and come back at what time? It is 12:21. So we will come back at 12:51. It's too great of math. We will see you then. We're going to go ahead and get started. All right. Next, we will be moving on to agenda item 7, the governor's proposal to modernize California's behavioral health system. The commission will hear a presentation from the California Health and Human Services Agency and the Department of Healthcare Services on Governor Newsom's proposal to modernize and expand California's behavioral health system. On March 19, 2023, Governor Newsom announced a 3-part proposal to modernize and expand California's behavioral health system by authorizing a $3 to $5 billion general obligation bond on the 2024 ballot to fund behavioral health expansion and housing for homeless veterans, 2, modernizing the Mental Health Services Act, and 3, improving statewide accountability and access to behavioral health services. As part of the proposal to modernize the MHSA, the governor is proposing to reorganize the commission by moving it under the California and Human Services Agency to increase coordination and outcomes, as well as restructure the commission by requiring the commission to become advisory and the executive director to be appointed by the governor. We will hear from Stephanie Welsh, Deputy Secretary of Behavioral Health at the California Health and Human Services Agency, and Tyler Sadwith from the California Department of Healthcare Services on the 3 elements of the governor's proposal, the impact on the commission's operations, and the commission's role going forward. I want to thank you both for being here today. And if I could invite you to please sit here up front so that we can look at. Thank you. Thank you for being here. Let us know if you need water. We have coffee too, and or chocolate, whatever. Great.
Okay, well, it's nice to be back. I feel would you be comfortable doing just a quick set of introductions for Tyler, unless you feel comfortable knowing who everyone is? I don't know if you've been here before.
I haven't had the opportunity to formally meet the commission members, so I'd appreciate introductions.
Is that okay? It'd be great.
Absolutely.
I'm Jeff Margolis. I'm the legal counsel.
I'm Mara Madrigal Weiss. I am the commission chair.
Rachel Chambers.
Hi, I'm Myra Alvarez. I'm the vice chair of the commission, and I run the Children's Partnership on it.
Myra.
Hi, I'm Michael Brown. I'm the sheriff in Santa Barbara County, and I represent sheriffs.
Al Rolette, a member of the commission.
I'm Gladys Mitchell, and I represent the parent of a child with a severe mental illness.
Steve Carnavale, I'm the governor's business appointee.
Mark Bontrager, I'm the Partnership Health Plan, Behavioral Health Administrators on the health plan appointment.
Good afternoon, Dave Gordon. I work as the county superintendent of schools here in Sacramento County.
Great. Thank you very much for doing that. So we do have a short presentation, a set of slides. Some of you may have seen some of these slides. There's a few tweaks to what we've been able to share before. And I really just wanted to open with saying that we're excited to be here, and hopefully we can have a lot of dialogue and use this as an opportunity to listen and take in some of the thoughts that you have about the proposal and take any questions. So I'll start first, and Tyler and I are going to walk through this together. And I think this is me. All right. So I believe the last time I was here was about a year ago. And as part of that discussion, and as you guys are well aware, it's been a busy time the last few years in behavioral health. So since 2019, with the new administration, there have been many significant investments. to reimagine California's behavioral health system, and really importantly, California's behavioral health system that's inclusive of substance use disorders and that's inclusive of people who are not part of the specialty mental health system. So individuals who are insured, who are getting their care either through Medi-Cal or also through our commercial insurance plans. To date, we have invested over $10 billion that's all state funds in a range of efforts that begin to build up the community-based care system and really focusing on some of the sickest Californians, those who have the most intensive needs, whether that be for children, young adults, or older adults. We also have really focused on investing in kids and young people through the Children and Youth Behavioral Health Initiative. And something that is really important to the whole backbone of this are the changes and the reforms that are being done through CalAIM. So really making our Medi-Cal program strong, based in evidence-based programs and able to reach beyond just the basic standard needs for behavioral health care. But we know that we have more to do. And when we were working on this and thinking through this, we thought we have a few more years of this administration that cares deeply about this issue. And while we may be a little tired from all of the work that we've been under and the massive amounts of change that we have been placing on all of our systems that serve people with behavioral health issues, it was really important to continue the progress and to move forward. So the proposal that we're going to be talking about today really is taking it to the next step and really filling continued gaps that we have in the system. That's a little bit about the context. I think I was successful in doing that once, and there we go. So the proposal, I think I might have skipped a slide, but just real quickly, the key elements of the proposal, there's really three pillars. The first is a general obligation bond. Want to underscore, it is a general obligation bond. This is not MHSA funds to fund this bond. The bond is really focused on funding unlocked community-based behavioral health residential settings, and we'll talk a little bit about that in a moment. The bond also has a component that's specific to meeting the needs of housing homeless veterans with behavioral health conditions. We also are making several proposed changes to the Mental Health Services Act, and really essential to the success of those changes, as well as other things that we want to accomplish as part of our overall agenda as part of this administration for behavioral health transformation, is to improve statewide accountability and access to behavioral health services. So I'm going to talk a little bit about the bond and then pass it over to Tyler to talk a little bit about MHSA proposed reform. So right now, to be fully transparent, we have not landed on an exact number, but we are in the range of somewhere between $3 and $5 billion. The bond has to go on the November 2024 ballot to get voter approval. The vast majority of those funds will be really focused on building those new unlocked community behavioral health beds in residential settings, and they'll be targeted for use by individuals who have mental illness or substance use disorders. I already mentioned the component for the veterans. So what are we really thinking about with these particular settings? As you guys are well aware, I think whether it was me or you guys have been following everything going on, we have this other program called the Behavioral Health Infrastructure Program. It's $2.2 billion to invest in behavioral health treatment settings. We are in the middle of round 5 right now. That is the round that's dedicated on building out the crisis care continuum. We've learned so much in that project and all of the fantastic ideas that many of our county partners and also just our health partners and other partners who are interested in building these systems through that project. And one of the things that we have learned, and you guys are well aware of this, is that we often have people who stay in a setting or a level of care longer than they really need to because there's nowhere else to go. And so 2 settings that we feel are really significantly missing in our state, and we're not going to be able to address those gaps through BCHIP, would be what we're calling, for lack of the right terminology, because we haven't given it a name, are what we call multi-property settings, or what would be potentially a place to receive care that is really focused on rehabilitation and stabilization as a decompression from someone who's probably coming out of some sort of acute care, or in institutional setting, coming directly out of jail, coming directly out of a state hospital, or also just having an acute episode, and they just simply need more time to rehabilitate. The analogy I often use with what this reminds me of in the physical healthcare setting is somebody has double knee surgery. We don't send them home. They can't physically care for themselves at home unless they have someone at home who can care for them in a very intensive way. This is a place where people can go to truly recover and have some time to stabilize without it being a long-term placement. The next setting is really another transition of care. We're calling them cottage-like settings, smaller residential settings where services may be available on site. But the idea is for this to be really integrated into the community. These are individuals who are living there. They're going to their appointments in the community. They're going to their clinic to deal with their physical health care. They're going to groups. And it really is preparation for independent, long-term, stable living. And that's going to be different for different people. Some people are going to go home. Some people are going to need permanent supportive housing. Some people are going to need shared housing. But this is really, I think at the core of what I think about when I think about these two settings is providing something that maybe there's a few of these somewhere, but hopefully having them more accessible in local communities so that people can be at the right level of care for the right level of time. And we don't just have people stabilized in hospitals or acute settings and then ask them to kind of go home or go back to the streets or what have not. So giving more time to recuperate is really the main theme with these two settings. And with that, I'm going to pass it over to Tyler to go over some of the reforms for the Mental Health Services Act.
Great. Thank you, Stephanie, and good afternoon, everybody. So what I'd like to do is touch on sort of the second prong of the three prongs in this proposal. Again, the first is really a general obligation bond to build up those new facility types that Stephanie described. The second prong is a sort of suite of proposed updates to modernize the Mental Health Services Act. And the third prong, which we'll touch on, are a number of measures to improve statewide accountability and access to behavioral health care. So the second component of the proposal really recognizes, I think it's helpful to quote one county, which is, the Mental Health Services Act has been amazing since it was passed 20 years ago, and it's been 20 years. I think since then, we recognize MHSA has really served as sort of a lifeblood of funding for mental health care in the state of California. And when it was enacted, it was really sort of monumental and foundational. And since then, in the past 2 decades, the national behavioral health policy landscape, not to mention the investments that Stephanie described that are being implemented under this administration, means that so much reform and so much expansion is taking place in our state that it behooves us to simply modernize and update the MHSA. So just to sort of quickly recap, since the passage, we've seen mental health parity and addiction equity legislation pass at the federal level, be implemented in state payers, including Medi-Cal. We've seen the Affordable Care Act pass, which covers now the adult expansion population in Medi-Cal, which now covers 1/3 of the state of California approximately. We've seen essential health benefits include mental health and substance use disorder treatment. And under this administration, there are roughly 12 behavioral health policy reforms under CalAIM. There are other aspects of CalAIM that are designed to address the behavioral health and social needs of Californians with serious mental illness. Stephanie mentioned the $2.2 billion authorized under the Behavioral Health Continuum Infrastructure Program. There's behavioral health bridge housing, there's care court, and there's the new Section 1115 waiver that we are submitting to our federal partners, the California Behavioral Health Community-Based Continuum Demonstration. So what this means is there's so much momentum, so many changes, so much new funding that the administration wants to simply adjust and enhance the MHSA to reflect those longer term investments. So to sort of summarize what those proposed enhancements and updates are, there's a proposal to update some of the categories that our counties spend the local assistance MHSA funding. The goal is really to lift up housing interventions and also provide more flexibility for counties to really focus on what their local needs are, including workforce, and also really design initiatives and interventions to address sort of target priority populations. There's a goal to broaden the target population served under MHSA to include individuals with substance use disorder. No longer would someone have to have sort of a primary or a mental illness to be able to be supported by MHSA. I think, in addition to all the sort of state and federal policy updates in behavioral health, we've seen the needs of Californians with behavioral health conditions change over time, including the opioid and now sort of polysubstance overdose crisis, which continues to result in record-setting levels of overdose deaths in our state. And of course, the housing affordability and homelessness crisis that all of our communities are grappling with. So this is really designed to sort of expand the scope of what MHSA can be used for to meet the most pressing needs of Californians. The goal is to also help identify and sort of specify that those individuals with the most vulnerable needs are prioritized for the most intensive services and supports under MHSA. There are proposals to strengthen the transparency and the information that is available to all of us, to all Californians, all taxpayers, all stakeholders, all family members, and all state and local administrators to know how the various funding streams that our local partners use to sort of cobble together a local behavioral health system between realignment, MHSA, federal financial participation. The goal is to really have more data available about how those funds are being spent so that collectively we can strengthen and improve the performance of the system. This would also include a longer term vision to look at what standard quality measures might look like across all counties for behavioral health. There's a proposal that the Mental Health Services Oversight Accountability Commission be brought into the administration to perform a more direct advisory and sort of policy-making process. As Stephanie mentioned, many of these components, though not all of them, will require voter approval. And so many of these will be included on the as a ballot measure in the 2024 ballot. And because we know many of these will take time to design and plan and implement, there's sort of a staged implementation approach that is being proposed. So I'll just sort of quickly walk through a number of these items. So the first item I mentioned are some proposed updates to the local categories where MHSA funds are sort of enshrined in statute or regulations today. These proposed updates really account for sort of the evolving needs of Californians with the most significant behavioral health needs, including the fact that you can provide as much treatment as you want to someone, but if they're living in an encampment or under a freeway overpass, it's really hard to get well and stay well. And so for that reason, there's a proposed 30% allocation of all local MHSA funds that would be prioritized and spent towards housing for individuals with serious mental illness or substance use disorders, or children with serious emotional disturbance. So this would include rent subsidies, operating subsidies, sort of housing, supportive housing services, as well as, of course, using these funds as the non-federal share for any related Medi-Cal services that are direct housing services, such as 6 months of rent and temporary housing that is being proposed under the California Behavioral Health Community-Based Continuum demonstration that I mentioned. There is a proposal to also, similar to the $1.5 billion behavioral health bridge housing initiative that DHCS is implementing. There is a component here that would be available to support capital infrastructure and capital development, and there would be sort of a process for effectuating that. The other updates to the local categories are really designed to, again, prioritize the population with the most significant needs, and then to provide counties with flexibility to adjust spending and allocate spending based on local needs and the stakeholder engagement process. So specifically, there's a new proposal that 35% of the local assistance be directed towards the full service partnership. And I want to highlight that along with this proposed allocation is also a new requirement that in order to meet the 35% spending requirement on FSP, only MHSA funds would be counted towards that. Today, we know counties use guidance from over a decade ago that allows counties to use federal funds, federal financial participation from Medi-Cal spent on sort of FSP related services to count towards their current FSP spending threshold, the majority spending under CSS. So this proposal would require that to meet the 35%, only MHSA dollars are counted in that, and that results in a net overall increase in the amount of funding allocated to FSP relative to what is being spent today. Finally, the third category of local funding would be 35% for other MHSA services. So this would include community services and supports other than FSP. This would include PEI, and this would include the WET and capital facilities and prudent reserve and other MHSA aspects. So this would really provide counties through the local planning process the ability to adjust those sort of allocations or their programming within that 35% to meet local need. There's also one sort of recognition that, you know, to align with other investments and initiatives, including the Children and Youth Behavioral Health Initiative that is being implemented in a multi-year process, that PEI in school settings specifically would be focused on sort of community level or population level or school-wide supports, programming, interventions, as opposed to individual services for students. And that is because the Children and Youth Behavioral Health Initiative is establishing a fee schedule, which is a all-payer fee schedule for mental health services for students. So just to provide a little more detail about the housing interventions, the goal is really to provide counties with the resources that they need to ensure that the individuals that they are serving are set up for success and are able to be safely and stably housed. And so 30%, we know that MHSA fund revenues fluctuate every year. Some years there's a dip, some years there is more revenue coming in, but approximately this totals to about $1 billion statewide. As I mentioned, this could be used for a number of sort of operational costs, operating costs, and supportive housing aspects, as well as an opportunity for capital development as well.
Can I add one quick thing here? And actually I might be next, but really it's important because we know how many young people are in full service partnerships, that this is also resources that can support young people and their families who may be experiencing or at risk of homelessness. Do you want me to do this one or you want to?
Go for it.
We put this together so that it would kind of help highlight how we see these two buckets interacting with each other, because I think there was a lot, it could be very confusing. And so as Tyler mentioned, that 30% bucket includes things like rental subsidies, operating subsidies, et cetera. That bucket is not intended for non-housing services and support. So those are things that receive Medi-Cal reimbursement, targeted case management. Now we have peer support services. We have community health workers. We're adding some additional things as part of our waiver that Tyler mentioned that's getting submitted this summer. So again, really it's about maximizing the dollars so that the MHSA dollar can be saved for what it's needed for, and there isn't another funding source for. So one example that we wanted to provide here is that we have a consumer who's in an FSP and they're placed in an adult residential facility, but that facility is uniquely designed for someone with complex co-occurring disorders. And that means that the facility has a lower staffing ratio, it has enhanced services for rehabilitation and recovery that are specific to SUD, and the cost of placement in that facility with those enhanced services is much higher than what is the non-Medi-Cal out-of-home care rate, which are the rates that are set for people who have SSI. And so the MHSA housing funds could be used as what is often called as a patch to fully cover the cost of that person being in that particular setting. And that patch could be part of the overall 30% requirement for housing. So hopefully that's a real crystal clear example of how the two buckets work together, and you're really keeping your quote unquote FSP dollars for the services and supports.
Thanks, Stephanie. And actually, just to further pull that thread a little bit, what this actually does is it frees up, I think, the local flexibility to sort of expand or enroll additional individuals into FSP slots, because I think the way this is conceived is that if someone does have housing needs, but is no longer interested in or really requiring or benefiting from sort of full intensive wraparound FSP services, this would be available to them, and they wouldn't need to remain technically enrolled in FSP, taking up an enrollment position. So hopefully this provides, more flexibility for local needs. Just to highlight some components of the workforce related proposals, again, counties would now have the expanded flexibility to use MHSA funding to address what we continuously hear is the number one challenge for counties and for providers, which is workforce. So this is not the silver bullet, but one arrow in the quiver designed to help California address the behavioral health workforce crisis that we're facing. So, examples of how expanded WET funds could be used could include licensing or certification, which, we know today is a barrier to individuals entering a career pathway. Loan repayments, scholarships, stipends, retention and hiring incentives, as well as other bonuses, so that we can see the workforce composed of individuals that reflect our communities. In addition, I want to highlight a key aspect here, which is that there's a proposal that some MHSA funding be used to sort of draw down or really leverage a significant amount of federal funding related to workforce specifically under the 1115 waiver, the California Behavioral Health Community-Based Continuum waiver that the department is submitting. And so this would allow California to use the MHSA funds as sort of the non-federal share for a 5-year demonstration period that the federal government will then match multiple times over. So the total volume of dollars available under workforce would be a multiple of what is allocated under MHSA. And this, again, would be directed exclusively towards expanding and strengthening the behavioral health workforce. As Stephanie mentioned, With respect to who in California it has the opportunity to be served and supported by MHSA under this proposal, that would include individuals who have really serious substance use disorder needs, but who do not necessarily have a co-occurring major mental health condition. And so this is really designed to help recognize that mental health, substance use disorder, these are not discrete silos. These are disorders that affect individuals fluidly, and that this would really expand access to life-saving care for a significant population in California that is continuing to succumb to increasing levels of overdose deaths. So this is really designed for those individuals who meet the clinical criteria in the DSM for moderate substance use disorder or severe substance use disorder, not really designed for sort of early intervention or other services for individuals with mild substance use disorder. Along with opening up the door for MHSA to be served for behavioral health globally, it would also, take steps to incorporate substance use disorder into various aspects of the program, including counties looking at substance use disorder prevalence and needs and unmet gaps within their local system to inform the 3-year plan development process. Another aspect of MHSA is really to sort of define the priority population that would be served under MHSA, in particular under the FSP category and others, really designed to ensure that adults with serious mental illness or substance use disorder who are experiencing the greatest vulnerabilities, including homelessness or risk of homelessness or experience with the criminal justice system or at risk of conservatorship, be those individuals who are really prioritized and within the local MHSA planning process. We know these individuals experience the greatest inequities and are at risk of the worst outcomes. And so the goal is to really meet the needs of individuals with the highest acuity and risk. For children and youth, there would be sort of a corresponding prioritization of the population served under MHSA with similar characteristics, including youth who are at risk of or transitioning out of the child welfare system. There is a desire that we know the administration has, and I know members of the public and members of the commission also have, which is to have a better understanding of what services are being delivered and provided and what outcomes those services are resulting in when they're funded by not only MHSA, but other funding sources as well. So there are a few proposals to address that and to sort of bring more data to the table. I think in order to get there or to sort of shape the type of data that we'll see, there are a few proposals to enhance or modernize some of the fiscal and expenditure aspects of MHSA. There is a proposal that to further strengthen what is currently a requirement, though not explicitly articulated to the extent we'd all like to see, a requirement that wherever possible, Medi-Cal be billed for services so that we can draw down and maximize our federal funding, which increases the amount of local resources that can be spent on behavioral health care. We know today many counties are maximizing Medi-Cal to the maximum extent possible. They're using MHSA as the non-federal share for all services, delivered, many services under MHSA. We also know that for various reasons at the provider level, at the county provider contract level, or just at the county level, MHSA funding is used at times to fully contract or purchase a service, even when that service could be billed to Medi-Cal. What that does is it limits the amount of resources that are available to spend on services. And so this would really require that Medi-Cal be billed when a covered service is being delivered, with the goal of infusing more federal funding into our local systems. There's a proposal to really reduce the amounts of prudent reserves depending on the size of the county. We know that the commission has been tracking and is aware that significant funding is in prudent reserves today. The goal of the prudent reserves, of course, is to ensure continuity of care and programming in the event of a decline in fund revenue. That said, the goal here with this proposal is to sort of right size those prudent reserve amounts so that we can maximize the funding spent on services. In addition, there would be a increased frequency of the reassessment of prudent reserves for that specific reason to ensure we are ensuring the security and stability of the program without sort of jeopardizing the ability to deliver needed care. In addition, there would be a recognition that counties would really be able to benefit from MHSA funding for administrative aspects, including outcome measurement, fiscal and programmatic data reporting, subcontractor monitoring, and other administrative activities. And so this would provide some needed flexibility to counties to support those activities. There is another proposal to modernize the 3-year program and expenditure plan in terms of the plan as a product itself, as well as the process that counties and local consumers and stakeholders follow to participate in the plan development. So the proposals for the 3-year program and expenditure plan are to simultaneously sort of expand the scope of that 3-year plan from what is today sort of an MHSA only, mental health only focused plan to actually have it be a global, local behavioral health spending plan, inclusive of substance use disorder, recognizing MHSA is proposed to include substance use disorder, and inclusive of all funding sources that counties use, including realignment, in 91 realignment, 2011 realignment, expected or anticipated federal funds, state general funds, county funds, et cetera. So this would really be a local county's all-inclusive behavioral health spending plan. There are also proposals to align the development of that plan and the outlook of that plan with other community-based sort of population health planning processes, including the new population needs assessment planning process that Medi-Cal managed care plans are required to implement, and the community health improvement plans that are required by local health jurisdictions. So the goal is for these plans, for the entities involved in developing these plans, county behavioral health, Medi-Cal managed care plans, local county health departments, to participate in the plan development process for each of these plans so that they are aligned and integrated and reflecting sort of local cross-system collaboration and spending. There are also some sort of more technical or mechanical proposals to allow counties to sort of streamline the plan reporting process, submission process to DHCS, as well as any adjustments needed to be able to evolve to meet local evolving needs.
So I think you would see a lot of things in what Tyler has shared so far that are things you've discussed here. There are things that have been discussed by many people for the last several years about things that would be helpful in terms of us really understanding what's happening. And that's so critical, because how can we invest our resources if we don't know what the outcome is on the other side? So also part of the proposal is to move the Mental Health Services Oversight and Accountability Commission underneath the umbrella of the California Health and Human Services Agency. And this is really to ensure that the work of the commission is connected to the work that we do across the entire behavioral health system. We have 12 departments, 5 offices, and I would say close to at least 10 of those departments and pretty much all of our offices are working in some way or space on behavioral health issues. And so really wanting to, as you can hear kind of from the theme of what's coming across in Tyler's comments, is that we really want to look at the behavioral health system as a whole. It's not just the MHSA, it's not just the specialty system that's managed by county behavioral health. It's really about what this administration has been saying since the beginning. It's about improving the behavioral health of all Californians, and all Californians are in different parts of the system. So the OAC will continue to examine data and outcomes. That is probably one of the top issues for this administration in terms of really wanting to change the way in which we drive policy, and to use data and outcomes to identify key policy issues, emerging best practices, to promote high quality programs. These are all things you guys already do. And coming into the agency, hopefully will give more opportunities to do more in this space. The OAC will still continue to report to the legislature and still include representation from the legislature, the representation you see around here, the incredible work that you do to engage stakeholders in the stakeholder community. Also the programs that you are directed to do, whether it be through the legislature or the administration, would remain under your purview. So not a ton of changes. The focus of the Department of Healthcare Services will really be to provide oversight of the fiscal allocations and county's use of funding. As you've just mentioned, as Tyler has walked through, and actually there's more to that piece around accountability that's coming up later in the presentation, but really having them focus on the oversight and their contractual relationship and those authorities that they have, and have the OAC be really focusing on research, evaluation, data, and outcomes. The last piece would be to have the commission, as becoming part of the administration, be advisory, and for the executive director be a gubernatorial appointees. This is pretty standard in terms of the governor's leadership in the posts that we have in various different agencies. I pressed the wrong button. Okay, sorry, Tyler. We're going back to statewide accountability. There you go.
Thank you, Stephanie. So thanks for bearing with us. I think we want to now turn to the third and final prong of this 3-prong proposal, which is to introduce a few measures to both the county system as well as the commercial insurance system that would expand access and strengthen accountability and oversight of behavioral health care in California. So there's just 3 more slides, and then I think we can open it up for some discussion. I mentioned, longstanding interest in knowing how MHSA and other funding sources are driving service utilization and outcomes at the local level. And so the governor's proposal includes a really expanded and strengthened scope of transparency on financing at the local level. And so this would require counties to report all funding sources used for behavioral health care, including MHSA, realignment, as well as federal block grant funding, which we do track today. It would include both the allocation and what they receive, as well as the expenditures, what they're spending on these, of course, with the goal of identifying any gap between the two. This would include a better view at what is being spent with block grant or realignment or MHSA only, as well as how those funding sources are being used to draw down the federal match or otherwise amplify those resources. This would include a look at any dollars left unspent every fiscal year, and broken out, of course, by funding source, as well as sort of a multi-year sort of aggregate unspent count by funding source as well. There would be a proposal that administrative costs incurred by the county to operate these programs be tabulated and reported, as well as information on services delivered to individuals who are uninsured or who have health care coverage from sources other than Medi-Cal. This would really help illuminate the extent to which MHSA or the state is sort of picking up the tab for behavioral health care delivered to people who have other sources of insurance. And there's a thread here that I'll pick up on it in just a moment related to that issue. So, it's really helpful to know, what sort of what the balance sheet and looks like at the county level. But in addition to increased accountability and fiscal transparency, there's also a goal to have more performance measurement data be reported and standardized across counties. So we know this will take time to develop and align on, but there is a goal to have both, many process measures that we know about, as well as actual outcome measures that show patient status and recovery and the outcomes that we all want to see be implemented, be standardized across counties, and be inclusive of multiple funding sources. Finally, there's a proposal to really continue down the path that the administration is pursuing under CalAIM to align the various Medi-Cal managed care delivery systems. So under CalAIM, the department is taking a number of steps to align the county behavioral health managed care delivery system. Today, every county is a mental health plan, and according to federal regulations and our regulations, those are managed care plans, as well as 37 out of the 58 counties participating in the drug Medi-Cal organized delivery system, which covers 96% of the Medi-Cal population. Those are also managed care plans. So, in alignment with CalAIM initiatives to align and integrate our managed care delivery systems, there's a proposal here to have the county managed behavioral health plans sort of meet the same bar that our Medi-Cal managed care plans have with respect to administrative infrastructure and capabilities. And so what that looks like is requiring key administrative positions, including a chief equity officer, chief financial officer, operations and compliance officers, chief quality officer. These are requirements that our Medi-Cal managed care plans have today. And we know individuals served through the specialty behavioral health delivery system deserve the same infrastructure driving their care as well. There would be a requirement for additional data reporting and collection, including network adequacy information, individual service recipients and utilization, quality metrics, that these would be, reported publicly, reported to the Board of Supervisors, and there would be a requirement that the Board of Supervisors attest that they are meeting their current and longstanding obligations under realignment. There would also be a new requirement for county behavioral health plans to form a member advisory council. This is a step we are taking at the department to further increase the direct input and communication that consumers and members have on policy and program design. And finally, there would be a requirement to implement closed loop referrals, which is a policy being implemented in Medi-Cal managed care. So the final proposal is something that, in my humble opinion, doesn't get picked up on a lot when stakeholders are discussing this proposal. But this is a pretty significant proposal, I think relative especially to what other states have done or have not done in this space. So this proposal is really designed to, as I mentioned before, ensure that, MHSA funding and local county funding are not sort of being used to meet the behavioral health care obligations of other payers. And so the goal here is to really drive further alignment between commercial insurance plans and Medi-Cal with respect to both benefits coverage, as well as with respect to what are called treatment limitations, whether there are things like prior authorization or whether it's things like a hard, treatment limit on the number of services you can get in a year. The goal is really to ensure that, youth, children of parents who are covered, as well as adults who have coverage, have access to the full comprehensive set of mental health and substance use disorder services that are covered today under Medi-Cal. We don't want people intentionally, quitting their job or dropping insurance just to get on Medi-Cal, just to get the behavioral health care we need. So this is a pretty monumental proposal to further advance the goals of parity. And there will be an intensive process that the Department of Managed Healthcare will lead to formulate this. So with that, I think I'll turn it over to Stephanie to sort of open it up.
Yeah, so I think that was a lot. And I'm glad that we got the time to kind of walk through it slowly so that there is a time to kind of let it seep in as to how complex and broad this is in terms of really reaching into all of the systems that serve people with behavioral health conditions. So we look forward to working with folks on the proposal. I wanted to give folks a little bit of an update of where we are in the process. We've had several conversations with a variety of different subject matter experts, stakeholders, et cetera. We've been working furiously to incorporate some of those things and some of the research that we've been doing into drafting language. And we are still in that process. It's really complex when you do all the things we just listed out to put that into legislation. So it is taking us some time to do that, but we are very eager to move forward with the next phase, which is to make some of that stuff public for consumption and for us to dialogue on. Honestly, I think that it's unclear based on all the things that happen when we do these things, what the specific process will be. But I think really the next stage is to get the language out and to start having really in-depth conversations about what it looks like. Very eager to start those. For our broader stakeholders, I think we'll have some engagement opportunities towards the later part of May. These things, again, are predicated on the fact that we need to put more information out there in order to have those. So more to come on that. Kind of a high level summary, and this is not, just wanted to share a little bit about kind of what we're hearing. I think probably the most often we hear, and I'm assuming that we might hear it today, and I'm very curious for folks' input, is this concern that we are choosing people with serious and persistent mental illness over trying to intervene early with somebody who maybe if they didn't have that intervention wouldn't end up having serious and persistent mental illness. And I think we really feel that that's a false choice. That's not what we're proposing. We've done a lot of analysis at the E&I of PEI and feel really confident that there are a number of funding sources to cover those services. Individuals are really getting actual services and care in that E&I section. There's, of course, a tremendous amount of value in population-based health approaches. And again, as we've lifted forward in this presentation, we really feel that there is still quite a bit of resources and a community-driven process that will determine how those other MHSA resources are used And of course, that planning process, we talked about public health being at the table for that conversation, the managed care plans being at the table for that conversation, and look forward to learning more if people have questions along those lines. I think the other question or the other current concern that we are hearing is that if we open it up to people with primary SUD, even if it is something on the moderate to more severe level, won't that eat up too many resources? And again, we also feel like that is a false choice, that it doesn't have to be, and feel really confident that our ability, especially with the work that has been done tremendously by counties in the last 5 years to implement the drug Medi-Cal organized delivery system, that we really will have the ability to, once again, like we were able to do with people with more serious mental health conditions, use the MHSA to be this engine to expand our ability to provide more SUD services for Californians. I mean, those are the two I hear the most. I'm sure there are others, and that's why I'll stop talking and have questions from all of you, however you want to facilitate this next phase of the presentation.
All right, thank you. So I want to thank you both for being here. And so at this time, I would like to invite commissioners to offer comments or questions to our presenters. Please, Commissioner Carnevale.
Thank you, Madam Chair. First of all, I think it's clear that we're all trying to get to the same end goal here. And so we're just fighting over priorities and organization and things like that. And I think we're probably in violent agreement about a lot of things that you're trying to accomplish because we've talked about many of them over the years. I find it interesting, this term modernization, because the very definition of the formation of the Mental Health Commission is transformative change. And we spend every meeting talking about modernization. So that's not a new concept here. And, you know, the commission has pursued goals around programs that have been outside this and other administrations' efforts around early psychosis, the full service partnerships, which I appreciate you connected to housing, to suicide prevention. It is, you know, to our mind, fulfilled at least some of its responsibilities to be innovative. So that's, I think, our viewpoint. I won't address all of those in the individual programs because other people here are better suited to that. But sort of with my business background, I think about the governance issue. And to me, the governance issue is not about this administration. It's about the very structure of government, and it supersedes this administration because it's going to apply to many administrations after that. And I don't understand the logic. The logic I hear is that it would be more efficient to pull all of these together. And that's like the Senate saying that they're going to bring the House into the Senate so that the government is more efficient, you know, or Trump would probably eliminate Congress and the courts to be even more efficient. But the very nature of the structure of this country is to have checks and balances. And that's exactly precisely why this was set up the way it was. More to my background in business, the reason private businesses are structured the way they are is around innovation. Big companies don't innovate. If you look at where new jobs are, almost 100% of new jobs are in small businesses, venture-backed businesses. That's where the innovation is. And big companies acquire them because they know that's where innovation comes from. The pharma companies have literally given up most of their innovation in order to leave it to smaller organizations. So I would put forward this idea that the Mental Health Commission is smaller and more innovative. It's structured to be that way. And I don't understand why we're going to eliminate what is effectively the Silicon Valley of mental health for California. We're going to roll it into the battleship, which by definition has to serve everybody. And you have a very tough job. We get that. But rolling it together from a governance standpoint makes no sense to me. I don't understand what you accomplish. I don't understand what is not happening today that you want, because the door is open for us to cooperate. And I don't understand what would be better if it was all rolled together. Thank you.
Thank you, Commissioner Carnavale. Any other commissioner, please, Commissioner Bontrager.
A couple questions. The general obligation bond, question regarding that. I think, just a general comment first. Our CBOs that do a lot of the heavy lifting and service delivery in this state for mental health, they're long on passion and oftentimes short on capacity because there's scarcity. And so I thought, one of the true values of this BCHIP program that's been rolled out is it's really enabled a lot of CBOs to expand facilities through public monies. So I wonder, as you look at the general obligation bond for these new settings, is the plan to be a similar format where we disperse that money to private nonprofits, or is that going to be publicly funded facilities? What does that look like?
We have explored building off of the BCHIP program for this, but again, lots of things are in flight. But have seen and are very pleased with the success of the program for many of the reasons you just mentioned.
Okay. And then a question about Mental Health Services Act. I understand with the new all-payer fee schedule, and then this idea of using MHSA funds for more, I would assume, like when you talk about groups of students, like the delivery of social emotional learning curriculum and stuff like that, which is great, but does that constitute kind of a cost shift? What is currently provided by schools will now be paid for by MHSA funds?
We didn't bring our CYBHI expert to the room.
Okay.
So I cannot answer that. I think what I can say, I'm not an expert on CYBHI, so I'd have to take some of those questions back, but they're really technical. But the idea is to focus on services that can't be tied to an individual. I'm not an expert on what the whole scope of social emotional learning is and if it's an individually based service, but this is things like a whole school approach to suicide prevention, stigma reduction efforts, other universal population-based type things that may happen at a school, true like prevention programs. You guys are an expert at prevention, early intervention, things that are really intended to raise the public's awareness, encourage help-seeking behavior, but you can't tie the intervention back to the individual. Is that an okay answer? He's more of an expert than I am.
No, yeah, I think that's right. And I think the focus on sort of school-wide interventions is to, recognize and scale up that this is happening today. There are, pockets in many schools and communities where this is a best practice. And so recognize that would be like non-duplicative with what the CYBHI fee schedule will do regardless. And so I think that question about cost shifting, if I'm understanding correctly, almost applies to the fee schedule itself, irrespective of the MHSA proposal.
Yeah, no, first of all, I'm in total support of it. I just don't want it to supplant what schools are already obligated to provide under multi-tier services and supports, as long as it's additive and not supplanting. Yeah.
I would like to go back. I have the same questions that Commissioner Carnavale has. And if you could respond to the question.
Was the question, what does the administration hope to gain? I'm not sure, or was the question, I'm not sure what the specific question was.
Yeah, what do we hope to gain by bringing this all together? What is not happening today that's going to happen tomorrow?
So I think I can speak for agency. And I think for us, we really see the potential of a real partnership inside. We have lots of databases. We have policy, obviously, that we're developing all the time. And being part of those conversations and being part of our team and our family. I understand your points about the separation of powers and governance. I can't speak to that. I think that's pretty clear what you said. But what I can say from our vantage point is we got a ton of work to do, and not just specific to the MHSA. As you mentioned, Commissioner, you guys are also doing a lot of work outside of the, kind of the public system. We really want to create change. It's about creating change for all Californians. And so we are doing a lot of that work. And I think there's an option or an opportunity to do some really exciting work together. with some of the things that we need to also implement. So-
And why could that not happen today? Why do you have to have a governance change in order to have a cooperation like that?
I can take that back. I can take that back. I can't, I'm sorry, I can't, I don't have the answer to your question.
Thank you. Please, Commissioner Brown.
Thank you. Two questions. One, prefaced by a comment, but the first question is that some of the early pioneers of the MHSA, Daryl Steinberg, Richard Van Horn, others, really advocated strongly during the development of the act for a disproportionate amount of resources to be spent on prevention rather than on services. And in fact, their recommendation was somewhere on the order of about 80-20, 80% prevention, 20% services. What's the drive? What is the reason to move away from the prevention aspect that maybe will prevent mental illness versus sort of going all in, or seemingly almost all in, on homelessness in particular? And I understand, and I think that we have considerable needs in addressing our homeless population. We have housing issues that need to be addressed. Certainly in my position as sheriff, I can tell you we need to do a lot more with substance abuse. But is this, are we robbing Peter to pay Paul here in terms of just taking the limited amount of money that there is and putting it all on one number or one color here, so to speak, instead of trying to be a little more strategic in terms of trying to prevent this from occurring?
So I don't know if Tyler wants to talk a little bit about the addition of early psychosis programs as part of our waiver, but I think what I would say is, again, like I said, we've looked at the numbers and feel really confident that it's not a choice, that there is potentially the ability to have more to do in the PEI section in particular that's not wedded to the structures of Medi-Cal. So if we go in and we look at all those early intervention services that are now reimbursable, that have another dollar to them, that frees up that bucket of PEI for more universal type prevention services, things that don't have any form of reimbursement with them. And that's what's been so amazing about the last 2 decades, is that vision, which I deeply believe in, I was there, deeply believe in it. We've been working really hard in our other systems to make sure they pay for that too. They need to pay for it too. You shouldn't just get prevention and early intervention services through the MHSA. You should be getting it through your Medi-Cal managed care plan, and you should be getting it through your commercial insurance. So that's what we've been really focused on, so that we can, again, the theme of a lot of the MHSA reforms are really about using that MHSA dollar, which I do think was the vision 20 years ago, using that MHSA dollar where there was no other dollar available. To do what needs to get done. And again, there will be a local planning process. We're not changing the fact that the communities themselves get to dictate how they want to spend that bucket, and they may want to spend the vast majority of it on PEI. We don't know. That's their choice. But I think we do feel really confident in that. And I hope we can continue to have more conversations and look at the data. And I don't know if there's anything you wanted to add.
Sure. Thanks, Stephanie. So just to sort of layer on, I think what Stephanie shared, the proposal to sort of reallocate the local assistance components is really, offers actually the ability to expand spending on prevention as well as early intervention, and provide more local flexibility to adjust that, so it's not sort of prescriptive from the state. And I think it's not like either or. And I think what Stephanie mentioned is key. I think under Cal-AIM, there are so many new services covered under Medi-Cal that are in the, prevention, early intervention side of the spectrum that, again, maybe are being funded, through MHSA in different types of ways today. But by covering them under Medi-Cal, including many services under Medi-Cal managed care plans, that frees up those funding under MHSA. So things like family therapy, dyadic services, community health workers, peer support services, mobile crisis, coordinated specialty care for first episode psychosis, and then moving into the more intensive FSP space, things like assertive community treatment, supported employment. These are all things that are either covered under Medi-Cal today or will be covered under the waiver. And so with the additional, sort of 66% federal match on all of that, it really frees up a lot of local funding to be reinvested and reprioritized within MHSA. And again, the goal for providing the new 35% allocation for prevention, early intervention, and CSS is designed to allow potentially increased spending relative to today on prevention, early intervention.
And then a comment with a follow-up question as well. The commission's current status as an independent body comprised of a very diverse group of professionals from all walks of private and public arenas is, I think, its strength. I think it's really what my being on it and learning what I've learned from the people that are on this commission has been what really is the hallmark of the MHSOAC. And there's concern, frankly, about this proposal to essentially, move the commission to the Department of Health and Human Services, and concern about the loss of independence, and also some concern about the potential of politicization of the commission, particularly with the governor's appointment of the executive director, which could, in theory, be a problem, and could really change the workings of the organization and the potential for having some mischief in the future. What is can you address that concern? Both of those concerns.
Okay, well, you guys can, what I can say is that I hear you. I don't have a response to say what I can't respond to something I do not have the authority to respond to. So I hear you, and I think that we are familiar with and would expect that that's what you guys would and how you would feel. And I've heard some of those concerns already. And so I can take that back. We've heard that from the legislative staff. So we are aware of that concern about you losing your independence, and that was part of why the commission was created. I want to acknowledge that I hear you. We can continue to have those conversations, but I'm acknowledging that I hear you, and we'll certainly take that back.
The other thing, the follow-up, Stephanie, to that is that, in your first bullet point on the MHSOAC, you say that moving the MHSOAC to the HHSA would be to ensure their work is connected and coordinated with the state's overall behavioral health system. But the reality is there are elements of behavioral health that occur in the state prison system, for example, in education and other areas that are really not covered by Health and Human Services. And so it's really, it's not a completely all-encompassing department. And there's concern. I represent criminal justice and the impact of that, as well as are we going to get shortchanged if this is how this ends up being, being taken under the umbrella of a state department that really has no dog in that fight.
I hear you.
Thank you, Commissioner Rolette, and then Commissioner Alvarez. And I also see you, Commissioner Bunch, and then Commissioner Bunch online. So please.
First of all, I wanted to acknowledge again, Stephanie, as you've said, you don't have the authority to answer that question, but I wanted to make sure that I endorse the comments related to the commission and especially Commissioner Carnevale's statement about being innovative, and that, again, I think that it is incumbent upon the commission to be charged with, if we are not being perceived as being innovative to respond to that and being given an opportunity to do so. And I've always endorsed, and subjectively biasedly so, that smaller entities, CBOs, have a propensity to be more innovative because again, we are not constrained as appropriately it should be as the government is. So that's part of my preamble, and I'm not expecting to respond to that. I just want to say I endorse those comments. My preamble is, and based on a data source, and don't want to get into where's my data source and refuting that, but some data that I picked up is that 30 to 35% of the people who are experiencing homelessness have a mental illness, and depending on where you look in California, where you look, you could corroborate or refute that. And of that 30 to 35% of the people experiencing homelessness, that 20 to 25% suffer from co-occurring issues or SUD issues. And it gets to what is my request. And what I heard today, I heard differently than I've heard before. So I'm going to try to articulate it in a way that makes, with some clarity. What's being implied here is that the perception that I have today that expanding the number of eligible recipients of MHSA services and not expanding the dollars will not adversely affect other funding streams or other MHSA funding streams. So for example, if a county is required to serve people who have been diagnosed with an SUD disorder and they have a percentage of their funding going to PEI, that they won't have to reduce that because there are other funding streams that can leverage, and I'll again say the financial match, the federal match is financial match, the federal match, that they could be able to pull down those additional federal dollars and be able to serve what I perceive as an expanded number of eligible individuals. That was, so you just said that's right. So that my summary of what you said is correct, sort of.
Do you want to provide any more detail?
Yes. And so what I'm interested in is an illustration of that, because if you could come back to us and provide us with information that would corroborate that and demonstrate that, because, again, I'm not seeing that in the data or information that I am looking at. I'm not looking at expansive population health studies at all, but the information I do have suggests that that's not what's going to be the decision that's made. So if you could do that, I'd appreciate it.
Yeah, I think we're working on a chart that would be available publicly hopefully fairly soon, that shows that, and you guys are really familiar with, you did some of this analysis yourselves, that if you require, at least just for the MHSA, that the MHSA is, we don't count the federal financial participation, but really just focus on the MHSA. That's one piece, but I think the other piece are the more exciting pieces, like having dyadic services being reimbursed, community health workers. I mean, you're more familiar with what are coming down the pipeline in terms of things that we've never been able to get any match for. And frankly, they're the things we know that work. And so that's really where we want to put some muscle in to grow our capacity to utilize those new services that are also now tied to reimbursement. And you don't have to use a whole MHSA dollar. It sounds like you have to use 34 cents, or I don't know. I can't remember I don't know what the average drawdown is. But I don't know if you.
Yeah, so that's right. Stephanie's right. And we would love to follow up and provide more clarification information. Is there can we get like a written, will there be like a written follow-up? I just want to make sure we're receiving the request accurately.
Well, again, as I appreciated in Stephanie's presentation, and I'll summarize that expanding eligibility and not expanding dollars, that there are other resources that will be available to serve the additional individuals who have been diagnosed with substance use disorders and not have to reduce the funding for, again, simply put, prevention and early intervention.
Got it. So the concern is that SUD, expanding the population to include SUD only without expanding total MHSA revenue annually leads
Yes.
to contracted resources. That's the concern.
Yes.
Okay,
And
understood.
we'll be happy to provide those to you in writing. We'll make sure that staff put them together and get those for you in writing.
Because that was not how I understood your question, so I'm glad you.
Okay.
Commissioner Alvarez, please.
Okay, great, thank you. Thank you, Stephanie and Tyler, for the presentation. I think it was really helpful to better understand the detail and see it laid out the way you did. I want to be mindful that I know we want to get to public comment, and there is a lot of public comment for you. But I want to go back to Stephanie, something that you said, really some of the feedback that you've already been hearing. First, I want to say, I want to applaud that the governor is raising this conversation of modernizing the Mental Health Services Act. It has been over 2 decades. There have been a number of changes. The question of whether we are meeting the needs of our communities is a fair one to ask. So I just really want to acknowledge that. And I believe that all of us are ready to have that conversation and determine what that best path forward is. But I do think from what we've seen and what we're reading, it seems to miss the opportunity of this whole family, whole child approach that we believe the administration has been behind since the governor came into office. The opportunity to work in greater partnership between the commission and the department has been something, as a commissioner, we've wanted to do, at least since I've been here, since for a number of years. So I'm encouraged that that is something that you want to see happen. And I hope even in these months, as the crisis continues to happen around us, we identify opportunities for that collaboration in ways that we may not have before. I do want to go specifically to prevention and early intervention and this opportunity to draw down federal funds. The CYBHI is a $4 billion investment, but it's a $4 billion one-time investment. And the crisis of young people is going to continue. We are all incredibly excited and so filled with hope for the all-payer fee schedule that will be used to allow schools to draw down Medi-Cal funds. It's an incredible opportunity, and applaud Melissa Stafford Jones and the team that's working that forward. But those services will continue to be clinical services. And not all of our children are going to school, especially our infants and toddlers that we know, as our former Surgeon General highlighted, how important those first few years of life are, and that mental health shows up in our babies and toddlers in many different ways. So we don't want to leave out certain communities. You keep referencing this analysis of funding sources for early intervention at the county level. I think it would be really helpful to share that analysis with the commission so that we can better understand the information that you use to make these decisions, and hopefully also be able to better understand or better incorporate that analysis into any feedback or opportunities for improving the proposal moving forward. I want to emphasize that we are partners in this work. And I think our shared responsibility to Californians is to ensure that our mental health system is responsive to their needs. And that conversation can start now. It doesn't have to start when the measure moves forward. So I want to appreciate the conversation and dialogue and make a specific request to see the analysis, particularly around early intervention and prevention.
Thank you, Commissioner Alvarez. Commissioner Bunch.
Hi, thank you. There was a lot of discussion this morning about how hard it is to bill and what services are considered to be billable. Do these proposals make this easier or harder for providers like FSP that don't do general outpatient services? I'm trying my hardest to understand, but my concern is that it might actually decrease our ability to help all of our community.
Thank you, Commissioner. To clarify my understanding, are you asking about billing Medi-Cal or other insurance companies, or can you clarify a little bit? I wasn't here. We weren't here for the discussion earlier this morning, which is why we're asking.
So what the discussion we had this morning is how many of the services that we provide, particularly in field-based services, aren't currently considered to be billable. And I don't know how this kind of ties into what I'm hearing a lot about the new payment reform, but a lot of the things that you do aren't face-to-face. There's a lot of case management that you wouldn't technically be allowed to bill for. And I'm just wondering if this is going to help with that.
Got it. Thank you. So
And it would specifically be medical.
Can you say that last part, Commissioner Bench?
Yes, I said, I am talking about a lot of times it is billing Medi-Cal that's difficult.
Got it. So I think that the goal of this proposal is to really sort of strengthen and expand and reinforce that Medi-Cal should be billed to the maximum extent possible. And I think to support that goal, the CalAIM initiative includes a number of behavioral health focused sort of program reforms or policy reforms that are really designed to support the provider experience and improve the provider experience, including with respect to billing and clinical documentation. So behavioral health payment reform should really make providers and clinicians' lives a lot easier, frankly, as should documentation redesign, which is also being implemented under CalAIM. Under the waiver that I mentioned and Stephanie mentioned, we're also expanding or really actually clarifying existing Medi-Cal coverage for a number of intensive in-home and family-based services for children and youth, including multi-systemic therapy, functional family therapy, and others. So I think in tandem with this proposal, there are a number of other initiatives to streamline Medi-Cal billing and make it easier to bill Medi-Cal. We could perhaps maybe follow up offline to learn more about in your county or in the counties that you have experience with, what is understood to not be billable today under Medi-Cal. Medi-Cal mental health coverage is pretty generous, pretty comprehensive. It includes the ability to bill and deliver sites in the community outside of a clinic setting. So it may be the case that clarification rather than new policy would help support billing Medi-Cal today.
Thank you. Yes, please. Commissioner Gordon.
Yeah, I just want to amplify Commissioner Alvarez's comment. With respect to the schools, I just give the administration and the governor all kinds of credit for the behavioral health initiative. I think much of that flowed from a lot of the work of the commission as an independent body, trying to make the argument that schools were a piece of the community, that the community itself was something that needed to be heard and responded to. And I think it's really paid off, because as we've gone through the initiative, just the fact of working with the managed care organizations, getting the schools involved with them, has built an awful lot of collaboration, an awful lot of trust for the future. And I'm just concerned that taking away the outside voice, which I think those folks have confidence in, the community folks, the school folks, that there are people on an independent commission that will bring independent advice to the administration. I think that's been very, very impactful. And I think it's resulted in good collaboration. And it's the old proverb that if you want to go somewhere fast, go alone. If you want to go far, go together. And I think this is a long journey. And I think the journey that we're on is really, really helped the fact that the commission has strong independent voices across the board, from our early childhood leaders to our community leaders to our law enforcement leaders. So again, I'd say stick with it.
Thank you, Commissioner Gordon. Please, Commissioner Mitchell.
Good afternoon. I have a quick question. As a parent of a child on this commission appointed by the governor. So in 2004, went back when the initiative was first passed, and the voters, there was nothing. And so the voters understood the need. And so now you're talking about modernizing the act. So I'm just curious, what is your communication or your marketing to the public? So what are you saying? Because you said that many of these initiatives here, you said will require, it's a ballot initiative. So I'm just curious, how are you communicating this to the public? And I would just like to hear how you're doing that and what is the public's response to this?
We are about just over 30 days, about 1 month out from announcing the proposal. And I expect to have a lot more public engagement. Once we have legislation, we obviously have the whole process that's associated with that. But then, there's so many things we don't know. We don't know if this is going to be fast or if it's going to be 2 years. Obviously, the coalition behind wanting to get this passed on a ballot initiative that's nearly a year and a half, I guess, away. I don't know that much is far away. But yes, you definitely need to have a coalition that's interested in these things and certainly have robust stakeholder engagement. We're right now really focused on getting more meat on the bone out there for people to chew on, to understand. And then we have a lot of work to do. I just want to acknowledge, and maybe it's something that you guys are interested in partnering with. Going back to Commissioner Gordon's point, being able in the work that you've done with your stakeholder bodies and, bringing in law enforcement and understanding what their perspective is, or education, or First Five, or health plans, that's critically important. We wouldn't envision any of that changing. Yes, I understand what you're saying about being independent, but that whole vision of what you're able to do and all those sectors, I understand that we're not CDCR and we're not CDE, but we work with them all the time. And so as fellow agencies. And so I think I would hope that that spirit of bringing all of that expertise and systems that are not real insular, so to speak, to just, the behavioral health system, in particular, what the MHSA was based on and what it's written above, which is the kind of the publicly funded county administered system, that's a huge asset that you guys have. That is something that is work that we're really interested in. You're involved. Many of you are personally and professionally involved in the CYBHI. That has been the spirit of how we have implemented the CYBHI. It is the spirit of how we are implementing CARE through our CARE Act working group that's representative of all sorts of external stakeholders to us. So I hope that you hear from me and from agency that work that you do to engage all those other sectors is really important. It's actually critical for this work to be successful. But I will also acknowledge Commissioner Mitchell that we have a lot of work to do. And hopefully that might be something through the structures that you have that you might be interested in partnering with us in getting feedback or reaching out to your constituents or networks.
Thank you. I want to move forward and make sure that we move on to our community. I'm sorry, I'm choking to our community input. But I did want to say this, since I've been a commissioner on this commission, our community stakeholders, our partners, one thing I do know is that when the MHSA was being brought together, community consultation was key. I mean, they helped shape it. They were there from the beginning, and it was more than informational meetings and just hearing from them. They were writing this alongside those creators. So I hope there's every opportunity for that to be happening in this process, and not just hearing from them, but really having them dive in with you and help shape every part of this. So I hope that is happening. We are going to make sure that we get those questions written for you and hope to get an answer. And Stephanie, I hear you when you say, I hear you. And I don't know what that means, but I hope we also get some of the responses that we've been asking for and just so that we have some of our questions answered, and we would greatly appreciate that. So with that, I know we have members of the public. So we are going to ask our members of the public, we invite you to stay here and hear from our members. So they may request to make a public comment on agenda item 7 by clicking the raise hand button on your computer or the app, or if calling in by phone, push *9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment. Are there any public comments? Please raise your hand now as the queue will be closing. We are going to ask that you please limit your comments to 2 minutes or less so we can accommodate as many as possible. Mariani, please open the line for public comment on agenda item 7. And we are going to start with people in the room first.
Okay, we have 3 in-room comments. First, we have Andrea.
Peer-run organizations. Should I start over? Thank you. My name is Andrea Wagner. I'm the Executive Director of CAMPRA, the California Association of Mental Health Peer-run Organizations. I'm also a person with lived experience, a peer. I'm a family member, and I am a mother of a minor child with diagnosed issues. I've also been involved in the justice system and chronically homeless. So I can speak to those, as well as working in crisis services for 5 years in my county as a counselor and a hospitalization coordinator. Anyways, I'm here today to really speak out to protect the Mental Health Services Act. I don't know where we got the idea that because a bill or a proposition is old, that we need to revise it. The Constitution, many of our laws are old. Does this mean we go through and revise anything that's over 20 years old? Sounds kind of tedious and worthless. I don't really hold that as an argument for modernization. I think it's just a political term to push an agenda of the governor. I want to say that 5 things. 1, stop going after Mental Health Services Act funds and let it be fully developed as it was intended. 2, stop ignoring and eliminating the consumer voice. We saw that across the board with the CARE Act, and we're seeing it again this year. Stop ignoring the consumers, and 50+ organizations. Thousands of people with lived experience across the state are being silenced in this process because we don't agree with the governor's plans, and it's got to stop. 3, leave the MHSOAC as an independent accountability organization. It's one of the few places that peers can come and actually be heard. It's one of the few places that supports advocacy grants like our CAMPRO LEAD program, which goes to consumers across the state and speaks to the hundreds and hundreds of peers all year long to bring their wants and needs and priorities back to the state. MHOAC is the only thing that does that. And my fear, after seeing how Cal HHS developed under the CARE Act, that will be eliminated once it is moved under that program. 4, leave prevention and early intervention alone, as well as innovation. Those are pivotal and monumental pieces of the MHSA, and you cannot touch them. It's deplorable to think that you would take money away from the programs that affect the racial and ethnic and peer support programs that are drastically needed and are why the MHSA was written by consumers all those years ago. And number 5, I keep hearing about all this money that's going towards these housing programs for behavioral health, and we were promised that there would be peer respite funding in those. I looked into that funding, and it is not built for grassroots or small organizations. It's built for a commercial system and a county system. It is prohibitive. It doesn't allow innovation, and so all these small consumer-based organizations that I represent are excluded from that funding. And finally, I'm here because my constituents are angry, scared, and disenfranchised. When we had a meeting and a hearing when this first topic came up in 2019 to modernize MHSA, There was a budget hearing and that room was filled. For 7+ hours, we sat and waited until we could do public comment. After all the hearing members had left, Daryl Steinberg had left, and we stayed. And for a good 2 hours, we one after another went up to the microphone and said, don't do this. And they're not here today. Why is that? We've been slowly and continually disenfranchised in this process. When you say stakeholders, I
Thank
laugh.
you, Andrea. Your time's up.
Thank you.
Sorry. Next in the room, we have Avery.
Good afternoon. My name is Avery Hulag Vicente. My pronouns are she, her. I am the advocacy coordinator under the lead program of Campro. And I echo everything that our executive director had just mentioned, but I'd like to speak very specifically on PEI. Although we have several concerns regarding the modernization of the MHSA, I will speak on this issue on PEI. We're united in our concerns alongside our many fellow MHSA partners and advocates here in the room and on Zoom. As a mental health peer consumer myself, my first experiences with major mental health crises occurred at the age of 15 and again at the age of 21, leaving me and my support network navigating a behavioral health system with little resources or direction. Through my work with Campro, I've learned that many members of the peer community had their first encounters with mental health crisis at a young age like me. And similarly, they lacked the resources and navigational support to understand what they needed to recover and get the help necessary to move forward in recovery. Research proves that investment in upstream and in prevention can reduce the onset of mental health conditions, and PEI services can provide the support, resources, and tools for children, transition-age youth, and their supporters to address mental health needs and navigate their paths to recovery out of the more restrictive systems of care. I strongly urge you all, commissioners, Health and Human Services, Department of Healthcare Services, to consider all of these comments and concerns that you'll hear from me, that you've heard from Andrea Wagner, and that you'll continue to hear as public comment continues, as you make these decisions regarding the future of MHSA funding. Please protect these funds for services that are client-centered, voluntary, and keep them in the hands of communities that have the best knowledge of serving their peers. Thank you so much for your time and allowing me the space to speak.
Thank you, Avery.
And then next we have Stacy.
Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. I just want to echo and thank Andrea and Avery for their testimony. I want to really commend and emphasize that REMCO stands for all of what they said. I also want to thank the commissioners because you asked excellent questions. I hope that are answered. And just to get this out of the way, because I want to talk about PEI, REMCO is concerned about this commission going under agency. We don't understand. I still don't understand what is to be gained by that. And certainly I feel braver now, thank you, to say that the OAC always has really better opportunities than I have seen so far in the meetings thus far on this, for people to talk, people to get their questions answered. And again, I could only think if this commission to go under the agency, it might revert to that. This letter represents the racial, ethnic, BIPOC communities, but also the LGBTQ communities, the children's communities, and the consumer communities. At first, I thought that my racial ethnic communities, we were the only ones, well, not the only ones, but that we cared most about PEI. But I found I was wrong. The LGBTQ community came to me and said, oh my God, our folks feel like PEI is the most important too. And so did the children's folks. And so I wonder why we are not being listened to and that PEI is in jeopardy. And yes, every county can make an own decision, but come on, that's 58 different battles. And that just isn't right. PEI is one of the only places where funding for CDEPs, community defined evidence practices, can be funded. And I think I do want to hear these other sources of funding for these PEI programs that are in jeopardy. There is a study.
Thank you, Stacy. Okay, time's up.
Sorry. Thank you so much.
Thank you, Stacy.
That was our final in-room comment. Virtually, we next have Richard. Your line's open.
Good afternoon, commissioners, and Tyler and Stephanie. Thank you for your presentations. With the full service partnership and the current happenings of the peer certification that's currently happening throughout the state, I'm one of the new students that just started last Saturday, and with the goal of becoming a certified peer specialist. I would like to recommend or suggest that in the contract, the 50% of the SP be peer certified. It's about peers helping peers. Let's not forget that at the state level, both with the Oversight Commission and the other two state agencies. Care Court was not intended for MHSA dollars to be used. It's obvious that the county wants to use MHSA funding for Care Court because they do not want to pay for it out of their general funds. The behavioral workforce, I'm kind of lost where we're at with that. I don't know if you're talking about social workers, clinicians, nurses. If that is the case, then peers need to be part of that workforce because there are peers out there that are working these professions. The deaf and hard of hearing community needs to be included in providing adequate mental health services throughout the state. The intellectual disability mental health community needs to be adequate served. Right now, there's only a few counties using MHS dollars to help those members of the community, both children and adults. The rest are being left out, inadequately served, and destroying families. The community planning process needs to stay as it is or expanded even more. Counties do not want this to be part of the process because they don't care about community feedback. The SMI unhoused community has been neglected under the MHSA when we could have had programs and services serving them. Nothing about us without us.
Thank you, Richard.
Next, we have Marianne. Your line is open. Marianne, your line is open. We'll come back. Next, we have Lori Hallmark.
Can you hear me now?
We can. You can go ahead. Go ahead.
Okay, very sorry. I am a retired lawyer who, with lots of lived experience, who used to represent state mental hospitals in Minnesota, which did a far better job for its mentally ill with fewer resources. I applaud CHHS and the governor for proposing to take control of this institution due to its scandalous history, repeated last night at 4:55 p.m. with a new directive to the counties on PEI, which our speakers probably haven't even seen, which continues the long history of robbing PEI funds directed by the voters for the poorest and sickest in a way that benefits the rich who aren't sick and never will be. If you aren't aware of this scandalous history, Google the San Diego Tribune and quote, bait and switch, close quote, to read a summary of the meticulously documented PEI bait and switch report from 2013, which is over 100 pages long, or ask the Trib or this institution for a copy of it through the Public Records Act because it was recently infected with the virus and I, for one, can't get at it. But as always, this institution in last night's directive ignored a mandate in the Mental Health Services Act for people who are already inflicted with severe mental illness which is in section 5840C, last clause. All you had to do, Commission, in last night's document to keep thousands of severely ill people out of jails and morgues and save millions of public dollars was to add that voter mandate in as one of your priorities. And instead, the sickest people have been systematically excluded from those priorities because of this institution's definition of TAY, which cuts off at age 25 when the average onset age of schizophrenia is 26, in women, 29. Last night's priorities are for kids, that's fine. For TAY, that's fine too. And for older adults, which the sickest schizophrenics never get to be older adults because they die 30 years early on average due to their diseases. So you left out the sickest groups. And you've been doing it since 2004. Now, I know that most of the people still here are trying to do better, but there are some ridiculous upstream PEI programs that should never have been funded, that are still getting funded, and that what people are going to scream at you for funding, which way they will get because they are entrenched and because the sickest people can't even talk to this institution because they can't even get inside the door.
Thank you, Mary. Your time is up.
May I put the actual wording of the statute in the, would you open temporarily so I can put it into the chat screen as a comment, because people need to know what the law actually says, the law that you all have ignored.
Thank you, Marianne.
I guess not.
Next we have Lori Hallmark.
So first, thank you for the opportunity to participate in this act of democracy. I'm encouraged by the commitment to reduce suffering. So a person who's living unhoused or who has disengaged from the system, they didn't end up that way in a vacuum. They tried to get help, and based on their experiences, they essentially gave up on the system as a source of help. So that's the end of the problem. So it's critical to identify and address the procedural barriers to access. So if I need help, what are the exact steps I must take? What do I have to do exactly to get the help I want and need? We need to look at the how. How does the system function in practice? Not how is it supposed to work, not how it says it works, but how does it really work on the ground? How many appointments, where and when? How many documents must I provide? What do I have to do just to get inside the door to help? And when I am in, what's next? What services are available? How are they provided? How do they work in practice? Where are they succeeding? Where are they failing? It's critical to obtain this on-the-ground information to be able to most effectively address the source of the problems on the front end, the factors that lead to that human being in pain, suffering, who has given up on the system as a source of help and the help it is offering. There's also a real opportunity to improve service quality by providing an independent, solid funding stream directly to CBOs and peer-run organizations. A secure independent funding stream could enable CBOs to plan ahead. If they had secure funding, they could create strategic long-term plans and they would be able to carry them out. Depending upon grants prevents long-term planning, and it also forces CBOs to tailor their services to the available grants. Additionally, if CBOs had secure funding streams that enabled them to not be dependent upon grants, they could assist in the on-the-ground accountability. Suffering hurts, whether it's ours or another person's, and as human beings, we want to alleviate it. Perhaps with some meaningful accountability for the barriers to access to quality services, we can. Thank you.
Thank you, Lori.
Next, we have Josefina. Your line is open.
Thank you, and thank you for the opportunity to provide some public comment today. My name is Josefina Alvarado Mena. I'm the CEO of Safe Passages. I also serve as the chairperson for the CRDP Cross-Population Sustainability Committee. I'm not here representing the Public Health Department, but I have three, I think, really important curiosities that I wanted to share after hearing the presentation. The first is about equity. And I believe the state has a commitment to reducing behavioral health disparities, yet the presentation was pretty much devoid of any references to that kind of priority. In fact, the word equity or equitable appears once in the slide deck and was only spoken a couple of times in the entire presentation. I want to really uplift the fact that multiple racial, ethnic, LGBTQ+ communities, including but not limited to African Americans, are overrepresented among the most vulnerable populations that you cited in your population, both for adults and for children and youth. I think it's very hard to imagine that how the behavioral health system can address the needs of the most vulnerable populations in our state without a community-defined, culturally responsive approach, especially when you consider the population that needs to be served. The second area that I wanted to raise is related to the CYBHI, and the fact that the CYBHI overlap is cited in the presentation, but the CYBHI is a one-time investment. And it's an investment that largely ends in 2025, the same year that this multi-year implementation, proposed implementation is supposed to begin. So there is a gap, especially in terms of prevention and early intervention work, and for certain populations that will not be continued to be served under the CYBHI kind of sustainability efforts. And that needs to be addressed. And the third area of curiosity is around the data. I did not, although I heard data reference, I did not hear or see any specific data presented that supports the reconstitution of the MHSA allocations, specifically data that shows the efficacy of reducing the MHSA's investment in prevention. And I think it's very important that there be a case made as to why this proposed reconstitution of the MHSA's investment will produce the desired outcomes that we're looking for here.
Thank you.
And finally, in closing, I just want to say that prevention, the value of prevention cannot be understated, particularly for our communities of color and LGBTQ+ communities. And there should be a continued prioritization on prevention if we are to ever stop the continuous stream.
Thank you,
of
Josefina, your
vulnerable
time.
populations that we're talking about today. Thank you.
Next, we have Paula. Your line is open.
Okay, I'm here. Hope, can you hear me?
We can. If you wanna
Okay,
go.
thank you. Sorry. So I'm Paula Ayala. I'm from Alameda County. I'm a parent, step parent of a person who's suffered from schizoaffective disorder under our current broken system for over 15 years, and one who could have benefited from preventative care since his biological mother also had mental illness and there was a predisposition. But I am glad that you're putting some more money into you know, the focus on the sickest as you promised, but I guess I really don't trust that, since the MHSA has stated from the beginning that the focus of it was supposed to be on seriously mental ill. That is not the same as just general mental illness. It's not the same as substance use disorder, although I know that it was amended to include that. And homelessness, those, by conflating all of those, it basically diminishes the original recognition of the urgency of providing for the seriously mentally ill. And so I appreciate the commissioner's question that we need more evidence that expanding the pool of people without expanding the money will not reduce currently served population. Despite Ms. Welch's denial that spending on substance abuse services will not necessarily take funding away from the SMI, the reality is that the Oversight Commission has, in fact, let that happen. The prioritization has not been honored, and I do believe that the Oversight Commission needs to be corrected, but not by basically codifying what the Oversight Commission has already been doing. I'm concerned that the choices and priorities will continue to fail to prioritize the most vulnerable despite repeated insistence. So there is clearly a problem in all of those areas today: homelessness, substance abuse, no question. But I want to point out that, yes, prevention, PEI services, but also the initial treatment services need to be quality. And that has been pointed out by a sociologist, Alex Barnard, who pointed out that most of what we have in our California psychiatric system has been private hospitals, which don't want to provide for.
Paula, your time is up. If you could wrap up. Next, we have Tara. Your line is open.
Good afternoon, Chair and Commissioners. Tara Gamboa Eastman with the Steinberg Institute. Thank you so much for the discussion today, and thank you to the Deputy Secretary and Deputy Director for your presentations. We really appreciate it. Our founder, Daryl Steinberg, was incredibly proud to co-author the MHSA 20 years ago. And I think we've all been incredibly proud to see the work that's been done, but it's also hard to deny the suffering that's happening across the state and ask ourselves whether or not we could do better. And I think we can. The Steinberg Institute is proud to support the proposal, and we're particularly heartened by the focus on FSPs and outcomes and accountability, and just really look forward to continuing to partner with HHS, DHCS, the administration, and the OAC as this proposal is developed. Thank you.
Thank you. Next, we have Kelly. Your line is open.
Thank you. My name is Kelly Ferguson. I'm the Director of Development at Rainbow Community Center. We are the sole service provider in Contra Costa County for LGBTQ people within a county of 19 cities and towns, and we're based in Concord, California. I'm deeply concerned about the reduction and cutting of PEI funding for the LGBTQ community that's recommended with this proposal, and leaving it up to counties to decide. PEI funds make up nearly half of the funding for our organization. It was mentioned today that there's a number of alternative funding sources, and I have to say I've heard of no such comparable funding for LGBTQ organizations such as ours. We support school districts and provide emergency interventions where schools are not equipped to serve and protect LGBTQ students and follow state and local laws of protection, and to meaningfully address and deal with the high rates of suicide, mental health challenges, physical attacks, and frequent bullying of LGBTQ students within our school districts. If PEI is cut or reduced, it's very possible that our organization would have to close our doors. Many LGBTQ centers in California are under-resourced and underfunded and rely on PEI funding. Our services and programs would be decimated if PEI is reduced or cut in our counties and statewide. Again, as the sole service provider for an entire county, thousands of LGBTQ and ally residents within our community, Contra Costa County, will have nowhere to go to get their urgent needs met were this change to be implemented. PEI needs to continue to be prioritized and ongoing funding with an inclusive process centering the community and service provider identified needs, and not redirected, cut, or reduced in order to continue to meet and address the safety and wellness of the LGBTQ community and to build inclusive communities throughout the state of California. Thank you.
Thank you. Next, we have Adrian. Your line is open.
Good afternoon, Commissioners. Adrienne Shilton with the California Alliance of Child and Family Services, and we represent nonprofit community-based organizations across California that are serving children and youth and families in public human services systems. So the governor's proposal from our perspective opens up an important dialogue about California's behavioral health system and has the potential to offer some opportunity for better care for our communities. And so there are many components that we want to better understand and really appreciate the dialogue today and the questions and the comments from commissioners. From the broad overview of the proposal that has been shared, however, we have concerns that this plan will scale back and perhaps even eliminate programs serving children's mental health needs, given the elimination of the set aside that 51% of funding under prevention and early intervention must be spent on children and youth. And so when suicide rates for children and youth are increasing and other outcomes are going in the wrong direction, this component to us seems counterproductive. So we understand the need, and we also support strategies to address the crisis of homelessness in California, But this proposal would eliminate the two components of the Mental Health Services Act that support critical interventions for children and youth and underserved communities. And that's the prevention and early intervention and innovation component. And so MHSA funds are used now to provide mental health services to children so they succeed in school. They support interventions that prevent childhood trauma and prevent child welfare system involvement. They also provide peer support strategies for communities of color and LGBTQ+ youth, as you've heard today. And the MHSA's promise 20 years ago was to move to an upstream prevention approach. And so all of this to say that in order to maintain the investments in a public health approach to well-being and true upstream prevention of disparities that can begin in infancy and compound across the lifespan, we need to preserve these existing protections and set-asides of MHSA resources for programs and services for children and youth 0 to 25. So we believe those should be maintained. Thank you.
Thank you, Adrian.
Next, we have Joel. Your line is open.
Hi, thank you so much. My name is Joel Baum. I work with a community-based organization in Oakland called Safe Passages. I just want to share a deep concern about the PEI funds and explicitly talk about the lack of certainty that I'm hearing in all the language. It was mentioned several times that, oh, there's plenty of funding opportunity, and yet the language referring to it was at best underwhelming. I heard words like, this will offer the opportunity for these kinds of funding. Local communities can decide to do this kind of funding. The fact of the matter is MHSA funding that is dedicated to the PEI community work is a firewall for communities that have essentially faced biased spending patterns that historically have not addressed some of our most historically underserved and marginalized communities. At times it felt like you were offering a lick and a promise to communities facing generations of trauma and unfulfilled promises. I'm beseeching you for the particular communities that Safe Passages and many of our sister organizations work with. It cannot be left up to the goodwill of others for PEI money to be in place. MHSA is one of the few places that explicitly dedicates that money, and we need you to protect it. I also just want to offer one interesting point about false dichotomies. I'm a former educator, and I found it interesting in specifically talking about the schoolwork when the shift is being made to whole school interventions and no interventions kind of on the individual level. And talk about a both and situation. Yeah, I love whole school interventions. My background is in education, as I said, they're great. But if you prevent young people, again, particularly those from these marginalized communities from accessing individual support services, you're leaving them high and dry. And it's simply unfair and against the spirit of this funding. So thank you again for the opportunity.
Thank you, Joel.
Next we have, sorry if I say this wrong, Eba, your line is open.
Thank you. Yes, my name is Eba Laye. I'm the president of Whole. We are an organization. We particularly involve youth whose mental health needs are not addressed in and virtually throughout the state. With PEI being taken away, we will never be able to serve those needs, and those needs will go unmet. I feel a little bit like the rug has been pulled out from underneath, because we have worked literally for years to make sure that PEI in LA County is more responsive. They have $1 billion in unspent MHSA funds. They don't do any competitive solicitations for PEI racial disparities. And now we're on the cusp of having the county address mental health disparities And now the proposal is to take that PEI away. The majority of the population of the state of California is people of color. In other words, underserved populations. The majority of people that aren't served is underserved populations. The disparity be greater, and to take away the opportunity for prevention and early intervention from people who are already not just underserved, non-served, and inappropriately served is a tragedy. Thank you.
Thank you, Ibai.
Next, we have Danny. Your line is open. You may go ahead.
Hi, thank you for allowing me the opportunity to speak. And I'd like to agree with a lot of the comments that have been said on PEI issue. My name is Danny Therical, Public Policy Coordinator for the California Youth Empowerment Network, a TAY or Transition Age Youth-led program of Mental Health America of California. And I'm speaking today to emphasize a potential adverse effect of the governor's behavioral health modernization proposal. As we know, funding for the Children and Youth Behavioral Health Initiative is one-time funding. The ability for counties to reduce or even eliminate PEI-funded programs poses a grave threat to the progress we've made in identifying mental health challenges in youth and providing preventative and early intervention services and supports to promote lifelong health and resiliency. Early investments in prevention reduce the drivers of mental health risks, such as unmet basic needs, poverty, and trauma. Our LGBTQIA+ and BIPOC youth are disproportionately impacted by these mental health risk factors and stand to most negatively impacted by any reduction in PEI supports and services. We recognize the long-term benefits associated with prevention and early intervention strategies. If counties are no longer required to fund or must reduce PEI programs, it would impact a whole generation and could ultimately increase the number of individuals with serious mental illness. Prevention and early intervention provide our youth with the best chances and outcomes. We urge reconsideration of the proposal to protect future generations and maintain the progress made to serve our most vulnerable communities. Additionally, I would just like to emphasize how difficult it is for youth to be involved in the decision-making process, and that making this governing body an advisory body, taking away its authority, would create an additional barrier for youth to be able to impact mental health policy that directly impact them. Thank you.
Next, we have Lasara. Your line is open.
Thank you. My name is Lasara Firefox Allen. My pronoun is they, them, and I want to thank you for this opportunity to speak to this issue. I'm the Executive Director of the Pacific Center for Human Growth in Alameda County, Berkeley. We serve the LGBTQIA+ community in Alameda County and beyond. I want to speak a little bit about who I am and just say that I'm a peer with lived experience. I'm the parent to a trans person with mental health and disability considerations. I have seen how folks benefit by the PEI funding. Our organization, as I said, serves LGBTQIA+ community. We're the oldest community center focused on LGBTQIA+ needs in the Bay Area. We offer free peer support services as well as sliding scale mental health services, a training program, HIV services, and we serve across the lifespan from ages 11. Our youngest peer group is 11 years old up through our older and out program serving our seniors. Our free services are supported by PEI funding, MHSA funding. And we, as Kelly said from Rainbow Center, which is a sister org of ours, I want to state that, I do not know how this will impact our service delivery for our population in the East Bay of California. The considerations that we have to get funding as we go is, as Kelly was saying, also a consideration that makes it hard to plan. And so having stable funding for prevention and early intervention services is something that allows us to serve our community in a way that we would not be able to without this funding. So I hope that real consideration is given to the fact that so many organizations are speaking out in this way and really fearing for the impact that removal of this funding would have on our communities. Thank you.
Thank you.
Next, we have Vera, your line is open.
Thank you. Thank you to the commission and to Stephanie and Tyler for all of the helpful information. As a peer specialist, I've been a child. I'm a child of the LA County behavioral health system. I receive services. I credit the public behavioral health system with basically saving my life. And I'm very concerned about the governor's lack of transparency. And I wonder who he's consulting in terms of deciding on these initiatives, which I believe are very harmful for community members and the people who are living unhoused and without support. I ask that you consider the peer voice and the consumer voices, people who have received services, people who benefited from the services through PEI funding, through MHSA funds. And I'm very concerned with the lack of transparency, and I'm hopeful, but at the same time, I'm very disappointed and pray for a positive outcome for the people of the state of California, but I don't really feel very optimistic. Thank you very much.
Thank you, Vera.
Next, we have the phone number ending in 718. Thanks, Steve. Your line is open.
Here, can you hear me now?
Yes, we can.
Oh, good, thanks. I can't really tell on this end. Thank you, Steve Leone, a consumer and advocate of many years. I do want to be supportive of a lot that's been said about the current role of the commission and the PI, but I want to move on to something else. First, I want to mention I met Rusty Felix and Richard Van Horn in the mid-1990s. I met Dave Pilon in the end of the 1990s, and I worked with him on several occasions as well, many occasions actually. And I was so delighted with his presentation earlier today. He talked about the village that I knew, the MHSA that I knew, that has inspired me for the last 25 years as an advocate. And one of the things he talked about was how shifting from billing they were originally using under the 3777 to Medi-Cal building was so difficult to accommodate, change the nature of the program, and how this has happened in most other programs where such a shift has been made. And you know, the thing about that billing, Medi-Cal still, even though CalAIM, look, I like it, good. It's way too, you know, it's been a long time coming, but it's nowhere near doing what the MHSA does. Frankly, that's not, you know, and anyway, billing and Medi-Cal is about illness. You bill for illness to count hours, etc. And as Dave alluded to, the billing in MHSA is much freer, and you can focus on what's going to help the person be a better person. And I want to remind you of that as we're hearing this proposal this afternoon. And I think it's like vitally important that any proposal that says, oh, we're going to cut back on PEI funds, but we'll substitute in Medi-Cal funds. That needs to be looked at very carefully. You're going to wind up killing the goose that laid the golden egg that had such good results 20 years ago. And one final thing that when they said that the new modernization means that you have to use Medi-Cal billing when it's available for something, you know, that's already the law. I can't understand why that's being
your
put
time
in
is up.
there as a modernization. It's already the law. Thank you.
Thank you, Steve.
Next, we have Angela. Your line is open.
Hello, thank you. Thank you to the commission for hosting this important dialogue and for your excellent questions today. I'm Angela Vasquez. I'm the policy director over mental health at the Children's Partnership. The governor's proposal opens an important dialogue around evaluating the impact to date of the MHSA and California's behavioral health system. The work to modernize our state behavioral health system offers an opportunity to better care for our communities. The current proposal of the reorganization of existing categorical funding seems to, however, unfairly pit children and youth, particularly children and youth of color who are most impacted by mental health disparities, against the varying and politically potent needs of county administrators, providers, and adults with severe mental illness for a smaller set of resources. With the information we have, it does seem that the current proposal is pitting these two very marginalized groups against each other for existing resources. Community-based and community-oriented Tier 1 primary prevention services are deprioritized in the proposal as it stands. Though current summaries of the proposal note that PEI dollars for schools should be focused on school-wide behavioral health supports, as noted by many communities since the MHSA was enacted, it is unclear just how much counties will invest in these upstream prevention services without preserving existing set-asides. Furthermore, the proposal neglects to address the significant need and previous commitments to young children ages 0 to 5, particularly through the work of the Office of the Surgeon General to reduce toxic stress and adverse childhood experiences. Because many evidence-based services for young children are not tied to an individual child's acute need, the healthcare system and Medi-Cal specifically do not consider them covered services. Dyadic care is a wonderful and very new exception to this general rule. Existing PEI dollars have funded many of these types of prevention services in counties and are imminently at risk of being deeply cut or wholly eliminated as a result of the current proposal.
Thanks, Angela. If you could wrap up.
Yes, in order to incentivize and hold counties accountable to hold child investments and a public health approach, we highly recommend that we preserve the existing set-asides of MHSA resources and consider creating even more specificity with a child and youth set-aside to ensure infants and toddlers are have their services protected as well. Thank you.
Thank you, Angela.
And next we have Courtney. Your line is open.
Good afternoon, commissioners and presenters. My name is Courtney Armstrong. I'm the Director of Government Affairs from First Five Association of California. Thank you for the opportunity to listen into this important conversation today. We appreciate all the questions that were raised and share concerns of the earlier speakers about the proposal, specifically around PEI funding. I think there was a statement made that an earlier commenter highlighted as well, that this proposal would almost potentially allow for increased funding for PEI services. But our experience has been that it's already been challenging for early childhood providers in particular to access PEI funding because of all the other competing needs. And so removing any requirements around that funding to us feels like it would just decrease the amount of money available for PEI, because it would be, as Angela pointed out, counties would be faced with sort of competing priorities and likely would choose to fund sort of the more emergent or urgent issues and rightfully so, in some cases, not fund the prevention services that we know are so desperately needed. This is a vital source of funding for early childhood providers that goes to services, as Angela also mentioned, that are largely not. We did analysis that looks at what services could be reimbursed by Medi-Cal, and we think it's more than 95% of the funding that's currently being used by this program are serving families in group and settings that are not Medi-Cal reimbursable. So just wanted to voice here that we're very anxious to see more details on this proposal. We do have concerns about losing this vital funding source for early childhood services. And so wait to see more and hope that this can be considered as the decisions are made. Thank you.
Thank you, Courtney.
Thank you. Next, we have Natalie. Your line is open.
Yes, good afternoon, and thank you for my opportunity. I'm Natalie Alsoon. I am the Community Engagement and Government Affairs Director with RAMS. I am acting in unison for a larger purpose and for the benefit of the wider community. Very concerned about the proposed modernization bill to redefine what prevention and early intervention should be and what it should look like for historically invisible communities. like Pacific Islanders, Southeast Asians, Blacks, and Latin. Addressing health disparities is not only important from an equity standpoint, but also for improving overall health and economic prosperity. Community-defined and nuanced solutions to prevent mental illness from becoming severe and disabling. We have found that in our work in San Francisco and Alameda County, it has proven to be very effective to create community-defined solutions that are outside of the healthcare system. And we often are asked, what is your evidence? The evidence is not many of our folks are coming into the system of care because their needs and they are embraced in their own community, in cultures and language that holds them and holds their mental health and health in general as a priority. So I stand in unison with everyone that are on this call to ask for the governor to, don't wordplay, don't wordsmith the bill, and that we are working on prevention and early intervention, not medical model, and not medicalize every issues that come forth into the policy system. And I yield my time. Thank you.
Thank you, Natalie. Next, we have Ale. Your line is open. You can go ahead.
Thank you. Good afternoon. My name is Ale Fernandez Garcia, pronouns they, them. I am a community advocacy manager with the California Pan-Ethnic Health Network. CPEN is very invested in making sure that any changes or reforms to the MHSA and the rest of the delivery system, for that matter, center and advance racial equity by making it easier for all Californians to access coverage by improving the overall behavioral health in our population and making sure that we have, most importantly, culturally and linguistically appropriate behavioral health services across the continuum of care. It must be ensured that diverse communities, especially Black, Indigenous, and people of color communities, and all the beautiful intersections within those communities are engaged in the development, delivery, and evaluation of services on an ongoing continual basis, and that the delivery system is held accountable to the needs and priorities of those communities. Bottom line, any changes to the MHSA should be in advancing racial equity and should absolutely center people with lived experiences to drive this forward. As many on today's call have said, no decisions about communities without communities. And so though CPEN is a statewide organization, I want to express our solidarity and the huge privilege it is to work alongside our community partners, peers, promotoras, and community health workers, some of whom are on this call today. Shout out to them.
Ale, if you could wrap up.
So, had to have so many innovative practices and solutions to many of the challenges we have discussed here today. We look forward to participating in shaping any changes that are forthcoming. Thank you.
Thank you. Next, we have Dana. Your line is open.
Good afternoon, and thank you to the Commission for the opportunity to provide public comment today. I'm Donna Pykow, representing the National Center for Youth Law. We serve and advocate for children and youth throughout the state. We also share the concern expressed by numerous others on this call that on diverting funds from prevention and early intervention will be harmful for children, youth, and young adults who rely on MHSA-funded programs and services for critical support. As the state has repeatedly recognized, including through its ongoing Child and Youth Behavioral Health Initiative, prevention and early intervention are powerful ways to address mental health needs early and mitigate negative life outcomes. We respectfully request that the administration assess the long-term implications of diverting these funds from mental health services for children and youth and reconsider this aspect of the proposal, and instead identify alternative ways to increase funding for addressing the critical homelessness crisis that do not lead to fewer resources for children and youth. Californians of all ages should have their basic needs met, including access to both safe housing and to needed mental health care. It should not be an either or choice of which services to provide or which age ranges to serve. Thank you for your time today.
Thank you. Next, we have Sharon. Your line is open.
My name is Sharon Jennings. I'm a resident of Sacramento County and a consumer of mental health services for more than 50 years. Thank you, Stephanie and Tyler, for your presentation, and good afternoon, commissioners. I have a simple question. Instead of diverting a portion, a very significant portion of MHSA dollars, why aren't we asking for money from FEMA? Everyone knows this is a nationwide disaster. And in addition, at least my understanding is that approximately 30% of the homeless population is right here in California. So wouldn't it therefore be appropriate to ask FEMA for help? We simply cannot do this alone. Thank you.
Thank you, Sharon.
And then next we have our last comment, Susan Gallagher. Your line is open.
Good afternoon, everyone. It's really great to see the community come out today. I think it's safe to say that the department sort of dropped a bomb on us with this whole proposal. And it's really disconcerting. I mean, some of the things that really stand out to me is the fact that we will obviously be serving more people with less funds if we open it up to everyone with substance abuse. So I really want to echo Al's comments around that. I want to echo the PEI community around all of their concerns. Sorry, I've got my little grandson with me today. And I just really, really am concerned about what seems to be an erosion of the community planning process. The stakeholders that are coming into play are not consumers and family members. It doesn't, like, I never heard the word client-driven, family-oriented. I never heard those. I never heard recovery-oriented systems of care today. I did not hear community-defined services. Those are the things that have really emerged through the MHSA as best practices and truly the evidence base that we are creating here in California. And it's very sad to see that there was really no mention of those things, which really, this is a new ballot initiative. This is not a refresh or modernization of the MHSA. It looks nothing like what the MHSA looks like in its original intent. I'm also very concerned about using MHSA funds to pay for rent. These costs are guaranteed to increase over time without a commensurate increase in available revenues. We've already had a method of controlling healthcare costs via Medicaid reimbursement rates, albeit imperfect. The costs have really skyrocketed in the hospitals where counties cannot always control the rates, and it's eating into precious mental health realignment budgets. And I really wonder about why would we get rid of the OAC if we need more accountability? That's just really counterintuitive. That doesn't make sense to me. Or put it under CHHS. If anything, we need to have more independence for the OAC. So I just really want to reiterate that I don't think that we should be marginalizing the OAC in this process of seeking more accountability. I heard a lot of doublespeak today where we're really opening up MHSA to be used sort of to leverage within CalAIM and all of that. So you hear this language of we need to treat and care for those who are the sickest of the sick. But then we hear that we're expanding to all of these other entities and agencies and other provider groups where we will be leveraging the MHSA. This looks like a money grab. This sounds like a way to leverage MHSA, but it's not anything to do with the original intent of MHSA. Looks nothing like it in its original form from our perspective.
Thank you, Susan, if you could wrap up.
Yes, thank you so much for listening. Let's do everything in our power to stop this.
Thank you. That was our last public comment. Susan was dropped earlier in the queue, so we took her now. If anyone would like to submit further public comment, please email our general inbox at mhsoac@mhsoac.ca.gov. Thank you.
Thank you. Thank you to everyone for joining us today to continue the work and discussions around mental health. We would especially like to thank members of the public. We value your input and participation. Our next meeting will take place on May 25th, 2023 in Los Angeles County. We look forward to meeting you then. Today's meeting is adjourned. Have a wonderful day.
Oh, God, come on.